Good morning, sir.
Hi, Navneet. Good morning. Nice to have you. Yeah, Nikhil. Hi. Good morning.
Hi sir, good morning.
So
Sorry,
nice to
I'm
see you.
using my daughter's laptop. भाड़े पे लिया है.
Nene, as long as you are there, we are happy, Babu. It's going to be a great morning.
Hello sir. Hello everyone. So sorry, it's coming as the name of Kushi. That's my daughter. So भाड़े पे उसका laptop लिया है.
कोई बात नहीं यार, absolutely fine. You still have about 6 minutes, no problem.
So sir, anytime coming to Pune, come over sir.
Let's see, yeah. I think it'll be more of a pleasure trip. Now, I think pleasure trips are more important than I think professional trips now. At least for people like us now. Who are the other side of the sun? You know, we are almost into twilight now.
Nothing like that, sir.
Navneet. Hi, Navneet. Are you there? Hi, Nitin. Good morning.
Good morning, sir.
Nice to see you.
Good morning, Nitin, sir.
Good morning, everyone. Good morning.
Navneet, we are having two students, Subhani and some Aarti. So once they join, they'll have to be, I think first is Subhani who's going to be speaking on the case. We'll have to make her a co-host. I don't think she has joined.
Okay, sir.
And the other girl is Aarti Sanap.
There is Aarti is also not joined, I think.
Yeah, still time.
So now these things are not at Nanavati Hospital. You're still continuing it because
no, COVID time, and we went off the physical form. We before that for about a year and a half or 2 years we were at Cooper Hospital, because Nanavati's auditoriums are getting busier with their own, I think, lecture series and training programs. So we opted out from there, and then we were very happy at Cooper. We had two auditoria there. One of the two will be available. And then COVID struck. So maybe let's see, by September, October, we should be going back to the physical form.
Right.
Yeah, unless this thing raises. What is your take on COVID raising its head again?
It's a scare, I guess. It's a scare and fear.
Yeah, I know. Yeah.
Science, actual science.
Because with this paper saying admissions have increased and this has increased, I think a little amount of fear has crept up.
Lot of drugs related to COVID are in store and they are getting wasted.
Morning, Nikhil.
Hello, hi sir. Good morning.
Good morning. All well. Good to have you.
Yes.
Today is your day.
Yeah.
AFGs, it's always AFGs day.
वो तो है. But we feel good.
Yes.
तू आता है तो अच्छा लगता है.
तो physical form करो तो आऊँगा. तो और मजा आएगा.
वो तो है.
को मिलेगा भी.
अभी शांति है. अभी शांति है.
My hospital doesn't give leave, but if I show something official, तो मेरे को 2 दिन का छुट्टी मिलता है. अगर आप 9 to 12 भी रखते तो भी मेरे को 2 दिन का छुट्टी मिलता है.
तेरे चाहिए तो हम लोग तेरे को हर हफ्ते इनविटेशन भेजे रहे. But I'm sure you prefer to work.
Yeah. No, but physical is always nice.
Good morning, Karthik, sir.
Good morning, Navneet.
I've made you the co-host also, along with Manoj.
Thank you. And I've sent you the names of the people who are presenting the case. So, you need to add them as co-hosts when they join in.
Yes, sir.
Yeah. Just give me a little time. Manor, we should start in 5 minutes time because 20 people have joined. Why should they miss out?
Yeah, I think we're just around 9:30, touching it.
Yeah, touching 9:30, 9:35, we can start. People who are presenting the cases have joined.
I don't think the first girl is Subhani. I don't see a name anywhere. So
Navneet have those children joined?
Sir, I
Not
can
yet.
see them. I can see one Aarti. I'm just trying to make her the co-host.
Aarti's case too, I think. She's R3 Sanap.
हाँ तो जो भी आया वो शुरू कर सकते हैं.
I'm trying
Actually,
to.
second case should be better with Yogesh. No?
I've asked
Yeah,
her to unmute herself.
we'll try to follow the protocol, Karthik, because let
Yeah.
us finish the early part earlier.
I think so. It's better that way. Yeah.
And Nikhil has promised us to hang around the entire length, so he's always going to be there.
Wonderful.
Aarti, can you unmute yourself?
Subhani is from Wadia, I think, or is she from Sion?
Shubhani is
She's from Sion. She's from Sion.
Okay.
And Aarti is from Wadia.
Okay.
There is one Aarti here. I think she's the one, but she's not answering.
That's okay. She's got time,
Okay.
because I
Yeah,
don't think we'll
that's
swap the cases early.
Yeah.
Karthik, any news from Rajkumar?
Raj and Mohan won't attend.
Okay, got it. I guessed as much.
Now he just sent a message.
Good.
I think Raju also won't join, probably. The fact that he's not joined till now.
No, Raju sent me a message that he is traveling somewhere and Wi-Fi may be a problem. I
Okay.
said, fair enough, no problem.
Yeah, fair enough. We'll have to wait till the person who's present in the case joins.
Yeah.
And I don't have a numbers. Mohan has not sent the numbers. So we can't get in touch with them. Because we don't have their contact numbers as well.
So you want to try Mohan and find out?
No, I've sent a message कि भाई तू number होगा तो भेज दे. I think let's wait for a couple of minutes. Otherwise, we can start with some opening remarks by Nikhil.
Who's come?
Manori said rank group में वो लोग का नाम और numbers होगा, तो let's see if we can search them out.
I'll do that.
Someone has raised a hand. Should I see what it is?
Yeah, yes,
Please,
just see what
please,
it is.
please.
Just see what it is.
रैन ग्रुप में नाम मिलना मुश्किल है रे.
हाँ, वही मुश्किल लगता है.
There are numbers are there and some
Yeah.
of them are.
Yeah. उसके सामने नाम तो मुश्किल दिख रहा है.
Very few are named with me.
True, same here.
Two 63 participants are there in one group. Where I'm going to get the number?
Difficult. No, and we don't have them named. So अपने को मुश्किल है.
Let me search. What he said, Shubhani.
Shubhani is an unusual name.
No, it's not with me here.
No, let's check the numbers if we get them.
There are two groups of RAN, no? 2 or 3 groups of
There are
RAN.
3 groups. There are 3 groups. मेरे पास एक ही है. I'm in one.
I've got RAN Symposia 3 with me.
Yeah, even I have the Grand Symposia 3.
That must be Mohan.
No.
See, what is going to happen, Karthik, is we'll have to swap otherwise. Take Nikhil's lecture first and
Yeah,
then
I
wait
think
for
so.
the student.
I think
Because
so.
there's no point people
No point in
waiting
sitting.
and joining
No point in
27.
sitting.
Yeah.
No point in sitting just like this.
So
I think let's start off.
Aarti is there. We'll have to wait for Aarti for the second part.
Good morning.
Yeah, good morning, Aarti. But I think we'll wait for your case because let's follow a particular protocol of finishing the early part of CS cervix and then go to the later part. And we will start with the lecture and then see if this girl Shubhani joins and we can have the case later. Nikhil, is that okay for you?
Okay.
Anyway, I'm talking
I'm
Dr.
absolutely fine. I'm there. I promised you till afternoon.
A great show.
Wonderful.
Anyway, friends,
Wonderful.
I think we'll go. It's about 9:38, 8 minutes beyond schedule. Welcome to RAN Symposia on Cancer Cervix. I carry greetings from Association of Fellow Gynecologists, from our president, Dr. Raju Saitya. We have a little smaller team today. Rajkumar and Mohan Gadam have got their, I think, professional, personal commitments, so they won't be making it. Karthik, I will be hosting the show, and we have experts with us, 3 big names in the industry of gynec onco. Dr. Usha Sarai, who's still to join, Dr. Yogesh Kulkarni, and Dr. Nikhil Parvatre. Very big names in the department of onco, gynec onco. Well, as you all know, the topic is a little drab, a little dry, but it carries a significant amount of weight from the exam point of view. So also from a practical point of view, what we should be doing. As all of us know, the way to prevent cancer is to screen and treat it early, or even just screen it and catch it without it being progressing further. Well, to go ahead, we are not following the regular protocol of the student presenting followed by the expert talking. We have with us Dr. Nikhil Parvati, who set the ball rolling for the morning. He's going to talk to us about screening for cancer cervix via A versus HPV. There's a lot of things happening in this field, and India perhaps is taking good strides. Nikhil will be the right person to give us an insight into this topic. Dr. Nikhil Parvati is a young, dynamic. Believe me, friends, he's really gone to the grind. I've seen him growing in stature. He was in Mumbai for quite some time, and he developed his love for onco after being a regular OB/GYN specialist, and he went into onco in a big way. Presently, he is the gynec onco and a robotic surgeon at Pune, and he's taken he's a student's teacher. Believe me, as we proceed further, you'll get to understand the amount of knowledge he carries on his shoulders and in his brain. So he is attached to the Aditya Birla Memorial Hospital at Sinswad, Pune. without taking more time, Nikhil, it's over to you. Thank you for joining us on behalf of AFG. Everybody, thanks you for being with us today morning.
Thank you, Motwani sir. Thank you, Karthik sir, and all the dignitaries at AFG. Always love to be associated AFG at any point. And anytime when I'm called, I'm always there for AFG. That is how I started my organizational work. I was a managing committee member in 2007-8 with Pandya sir as the president. So a lot of memories of AFG with me, and I carry it every day with me. Thank you for giving me this opportunity. Thank you, Motwani sir, for facilitating everything for me to have this platform. Can I start my screen sharing?
Please.
Is my screen visible? Am I audible?
Yes, sir.
Okay, so as Motwani sir said that it's a dry topic, but believe me, I'm going to make it very interesting. Cancer cervix screening and prevention is not what actually we learned. Even we thought that it was very dry subject, but overall the things have changed so drastically and so rapidly in this field that the entire process of cancer cervix screening thought process prevention has changed. So I'm going to, and I think, yes, everybody must be wondering why I have chosen this topic, because I understand all of them are students and this is what is going to be the future, right? So all students must be wondering this, why am I talking about this? Where is Pap smear gone? We do it daily in our hospitals. So let us all agree and conclude that India has not just done justice to Pap smear, and there were problems at every point, and doing Pap smear has not helped us reduce the burden of cancer cervix. We all know that cancer cervix and cancer breast have a cat and a mouse fight in staying at #1 as to who is the biggest killer cancer of women in India. So we have not just done justice to Pap smear, whereas the Western countries like UK, systematic screening by Pap smear from 1960 till today has got down the incidence of cervical cancer by almost 71%. But we have not done justice to Pap smear. There are problems at every point: collecting Pap smear, fixing, labeling, transporting, reporting, interpreting. Everyone is doing everything in his own way. In fact, when I joined my hospital in Pune, for first almost 18 months, I just did an audit of Pap smear. Believe me, there was fallacy at the very starting point of collecting. Majority of the gynecologists were also not aware as to what is the correct method of collecting Pap smear. So everything from then on changed. I'll be telling you how we change and what we are currently doing now. We are completely out of Pap smear in my hospital. And what happens is Pap smear is everything laboratory dependent. And let me tell everyone that COVID has taught us that everything is not lab dependent. You know, there were CT scores, and then how CT scores increased unnecessary hospitalization, and then CT scores were stopped. So lab dependency is not what a clinician would like or love to do, and especially when you are trying to do screening where women are, as it is, very scared to come up forward. I think we need to have system which is completely lab independent to make the process of screening effective. So now this is what the WHO has said, and this is for all lower middle income countries, including India, that we are supposed to eliminate the cancer cervix by 2030. And what they mean by elimination is our incidence should be up to 4 or less than 4 per lakh population. And for that, they have set the 90-70-90 rule, which means 90% of the girls should be fully vaccinated by 15. 75% of women should be screened by high performance test at the age of 35 and repeat at 45. And 90% of women with pre-cancer treated and 90% of women with invasive cancer should be managed. So each low middle income country should meet this 97-90 target by 2030 to get on the path of eliminating the cervical cancer within this century. Now, this is a very big statement. Even Foxy has taken this very seriously. I want the AFG also to take this very seriously, and we have to have some strategies, and these strategies are not just organization or association based. These strategies are in conjunction with the government, because if there is government participation, we know how COVID did in our country. Yes, we really controlled it very well. And for all these to achieve, organization, association cannot take certain positions. We know what are things which we can do and which we cannot do. So unless and until AFG with either the Mumbai Municipal Corporation or the government in Maharashtra and Mumbai does something on a very large scale footing, this 90-70-90 looks to be a very, very distant target. So all the postgraduates should know that there is a WHO call for cervical cancer elimination. 90-70-90 is the target, where vaccination, screening, 70% of screening has to be achieved, and 90% of the women should be of pre-cancer should be treated. So this is what is going to be the road further. Foxy has taken it seriously, but I think even in Mumbai, I think strong organizations like AFG should take this further. We are talking of cervical cancer Mukt Bharat, but to understand what WHO put forth, India is still a distant dream from it, because we all have to understand that we are still categorized as third world country, low middle income group country, LMIC. We today do not have any national screening policy of screening. And believe me, what I come to know from the cancer registries in the country, 11 to 15% of the people, of the women or eligible women are screened. And what we call that we are doing opportunistic, but what I understand, it is not opportunistic. It is random, haphazard. So if a gynecologist or a healthcare person is seeing 100 women, and probably he may think of doing, screening in 4 or 5 of them, he may not do in 4. So it is not opportunistic that the patient comes and you do it. The patient comes and you do it. It is like, okay, chalo, I remember about, doing a screening test. So that's why I do it. So more than opportunistic, what I find on the ground is random haphazard screening. And what happens is everybody is doing screening as per his or her own will. So what my infrastructure has, I can do that type of a screening. So what is happening is everything is done in a haphazard, randomized way. And we are talking of having a cervical Mukt Bharat. It's like if we go to buy a flat, we just cannot start the interiors, thinking of doing interiors first. We need to select our builder, we need to select our building, we need to select our flat. We have to do a lot of paperwork in that, and then whatever house decoration occurs. What we are doing here is first we are thinking of house decoration, leaving behind the basic things in a cervical cancer screening. So if we want to achieve a cervical cancer Mukt Bharat, first we should all our gynae organization association should be pressing the governments, the municipalities, all those people who are the stakeholders in healthcare on having some clear national policy on screening. And when you talk of national policy of screening, you cannot have just all types of screening taken into burden. Why? I'll tell you. What is happening is, in our, what I see ground reality is, people talk about doing screening and cancer, and the entire gamut of pre-cancer lesions, which the WHO says that 90% of the pre-cancers has to be treated, is completely lost. So CIN1, CIN2, CIN3 is completely lost. So you only do screening and directly talk about Vardyne. So that is what is happening. So if we are not having any formula of identifying a screen positive and making efforts at treating them in a pre-cancer stage, we cannot have a cervical cancer Mukt Bharat. It will just be like any other political headline. So all students must understand that, and it is fact, it is given in your TLINs also, pre-cancer lesions of cervix, CIN. There is a very big chapter on it. And then after that, you have the chapter of cancer cervix. So unless and until you don't know about CIN 1, 2, 3, as students, you have no right to talk about cancer stage 1, 2, 3, 4. So this is the problem, that we have not been able to do justice with the pap smear. Everything is haphazard. I mean, we are giving a very flowery name called opportunistic, but it is not that flowery on ground. It is more of haphazard things. And we need to somewhere admit that, okay, pap smears have not gone the way it should have been in our country. There is nothing demeaning to say that. Not that pap smear process is wrong or the process of pap is wrong. It is the entire thing that we have taken over in our country has completely misled us, and we are on the wrong path of cervical cancer screening also, prevention also. So then what is the solution? We know the problem. I think we should revise whatever is taught and done. I am very clear that for at least next few years, teaching in the medical college as far as cytology is concerned should take a little backseating. Maybe I have written here stop. I don't know whether it is right, feasible, or whatever it is. That's the call of the heads in the medical college. But cytology from the medical teachings as far as medical colleges should take a backseating. It should come at number 2 and number 3. And most important, every student should be taught what is the definition of screening. The definition of screening is given in PSM textbooks, and even our teacher, who is now retired professor and head of gynec department, Dr. Rajendra Kerkar sir, used to tell us in his lectures, acceptable, accessible, reproducible. This is the meaning of, or the definition of screening test. And whichever test you take, okay, should be able to meet these 3 criteria, then only it has to be taken as screening test. So I'm sure that as far as pap smear cytology is concerned, we have not been able to reproduce it anyway. Second, it is not accessible. I mean, probably a woman in a hill or a town will who's staying on a hill or in some rural area where they don't have healthcare facilities, she is not going to come to you to do a pap smear, go back home, and again come back to you after 7 days to collect a report. And I'm sure the healthcare centers are not equipped enough to either print. They'll have to send it to rural hospital, again the rural. So a lot of things are there. So I don't think so cytology or pap smear, what you call it, fits currently the definition of a screening test as it is defined. So we have to understand, all students have to understand that the biggest randomized controlled trial on screening on cervical cancer is done in India. For a change, I'm very happy you don't have to take clues from US and UK, neither ACOG, neither RCOG. I'm very happy about that. And this was a landmark project which was done at Barshi, Maharashtra, in association with Tata, WHO, UNICEF, IARC, Ministry of Health, Government of India. And all 4 methods, this was somewhere in 2008-9, this was done. And all 4 methods of screening were put to test: the pap smear, the HPV based, the VIA based, and even colposcopy as a screening test. Based on this, we also, the students also need to go through the FOXY GCPR guidelines, which we had formulated at a meeting in 2016 in Mumbai, where Saraya madam was in charge of it, and she also has made a lot of contribution to this. And there are FOXY GCPR guidelines which are available, so that when you're going for exams, you should at least read these guidelines before going to anything. But you need to know that this largest RCT on screening was done in India, and there were beautiful results for each of these tests: PAP, HPV, VIA, and colposcopy, which to be used as screening methods in low middle income group countries. So what are these HPV based tests? HPV is human papilloma virus. You all know there are about more than 200 strains found, 1618 being the one which are associated with cancer. 611 is one which is associated with genital warts. So how do you do this HPV test? Now this HPV test has been done by PCR also. It is done by a hybrid capture 2 also. But PCR is not the method, because many labs are offering HPV PCR. I think that is not an acceptable method of doing an HPV test. The acceptable method of doing HPV test is hybrid capture 2, and that is what every one of you who is ordering this test should be demanding from your laboratory. So, and it is done through the liquid based cytology jar. So you have that jar which has a liquid and a brush in it. You have to put that brush with bristles into the internal os and rotate it around 4 to 5 times, and put that brush into the liquid and tease that what collection into the jar. So that is how liquid-based cytology-based HPV test is done. As I said, PCR is not the accepted method. HC2 is the accepted method. Good thing about HPV test is more than sensitivity, specificity, it has a very high negative predictive value. So a negative test means the woman is negative on HPV is one of the hallmark of this particular test. And the results of that RCT at Barshi said, and everybody has to know about that randomized controlled trial will occur at Barshi, and all students need to read about it. It is available everywhere. And a single test at the age of 35, and if negative, can be repeated at a gap of 10 years is what was the conclusion drawn from the Barshi project. And please understand, do not do HPV test in women under 30, simply because under 30, every woman most of the times will be HPV positive. So there is no point unnecessarily burdening a young woman with a positive HPV test. It's going to cause more harm. So that is why it is to be done only for women about 30 years. And that too, if they have an ASCUS or an LSIL cytology, if at all you have done a cytology. So that is what is the very clear-cut indication of doing HPV test, how it is to be done, whom it is to be done, and whom it is not to be done. So what are the on-ground problems is that in order to make the test less expensive, people are offering PCR. So I guess a HPV PCR is done, I don't know if I'm not mistaken, somewhere around 500 rupees, where the original HPV DNA HC2 costs somewhere around 1500 to 1800 in Mumbai. Women under 30 are unnecessarily able to undergo this test. It does not currently fit in the definition of screening test, because in a rural area, getting those jars, getting those HPV kits in the rural health center, the women undergoing this test, then the sample going to the lab, then they are printing the report, and this report going back to the treatment. So this is the same process as what the cytology is. Because after all, HPV, again, I said, is a lab dependent test. COVID has taught us how to be independent of lab, because whatever was done in the lab was not good for the patients at that time. So every time a higher, and second problem is, if you have a COVID, if you have a HPV positive 16 and 18, but then on cervix you don't see any lesion, of course you don't have to worry, but the patient worries. It's a psychological impact on the patient that I'm carrying a virus which is positive, which is going to cause cervical cancer, but currently my cervix, as per the doctor, is not showing any lesion. So how long can I wait? The doctor says that your immunity is going to clear this infection. So how long should I wait? How long should I be, going to the doctor to understand whether I have cleared this this infection or not? And for that, how much money will I have to spend every time? So I think I know very clearly in my practice, the only time I take help of a lab is only for medical legal things, so that somebody doesn't say, "Bhaiya, tumne ye test nahi kiya," but I give zero importance to the reports. Patient's clinical findings tells you 90% of the things. So let us have a system where we are independent of the labs. And although this test is very promising, okay, we require a very clear national program specifying every aspect of the test, including how, when, what to interpret. So as far as I'm concerned, HPV is the test. Yes, it's definitely the test for cancer screening. But in India, we need to hold it back for at least some time, till the time we do enough groundwork in understanding and screening our own, and having at least a target of screening, so as to understand what will happen in the next 5 years. So I think probably in the next 3 years or 5 years, we should be looking forward upon an HPV based screening test program. Not now, because we have to first sort out the ABCD, because it is lab dependent. So then what next? So if we want to achieve what WHO says, then we may have to look at something which may not be very accurate or sensitive like HPV, but one which is qualifying all the three criteria of a screening test, that is acceptable, accessible, and reproducible. And this can only and only be done with VIA. I am not sure how many senior teachers from AFG are listening to this, but I'm sure all of them have been, coming up, have reached what they have reached today by initially doing this test. And with artificial intelligence also added to VIA, it becomes all the more reproducible, because initially it was thought that it cannot be reproducible. There were a lot of subjective issues with the test, and everybody interpreting its own way, so that human error related issues is now being completely taken off from this test by addition of artificial intelligence, and I'm going to come to it in some time. So visual inspection of acetic acid, I think every medical college in this country should have a VIA clinic, and all the screening should be done there, because if you see, hardly anything is required, just a speculum of freshly prepared acetic acid, a Lugol's iodine. All the students, you need to know how Lugol's iodine and acetic acid is prepared. You need to know that. And the IARC, that is International Agency for Research in Cancer Screening Group of WHO, has also given those pictorial charts where you can compare the results of an VIA test. So if it's a healthcare worker, so if for the nursing home owners, even if your sisters can do it, you can just keep that chart in front of you, do a VIA, see if it is positive, see if it is negative. If it is negative, your patient can go home and come back after 3 years for a repeat VIA. So it is so simple. It will be less burdening on the gynecologists, as most of the gynecologists I have interviewed and questioned are not very keen to do a screening test by themselves. They would say if they would have a subordinate to do it, they'll be far off better, and then only doing the interpretation of results. So VIA is the one test which will allow you to do that, and not Pap smear, because Pap smear and HPV, the gynecologist herself will have to do it. Here, even their trained staff or their RMOs can do it. So it is so easy. So we can succeed only in this country when a woman in the remotest area undergoes the same cervical cancer screening test which a woman in the most highly placed infrastructure hospital undergoes. And you are able to get that report immediately, and she gets the related service. Remember, students, that it is not just doing a screening. You should have facility to treat the screen positive. You cannot say, I have done my job of screening, your report is positive, I don't know what to do with it. You do yourself. No, that's not the idea of a screening or a prevention program. You should have facilities for colposcopy, because all screen positive, whether you do HPV, VIA, cytology, the next test is colposcopy. You should have colposcopy services. You should have facilities for colposcopy biopsies, and you should have facilities for colposcopy related treatment. So otherwise, we are not going to have a cervical cancer Mukh Bharat. We cannot achieve an elimination, we cannot be on the road of elimination by 2030. And we oncos will still keep on doing Vardheims and exenteration surgeries for CA cervix. So what is the solution is that a woman anywhere in the country who is in front of any of the health infrastructure, be it in a rural area or be it in the most metroist area, they should have one test which is to be performed, and that result interpretation should be uniform all around. So as I said, VIA is very simple, and it can be delegated to the lowest of the hair care worker. In the project which I'll be talking about, we have asked the Anganwadi Sevikas to do it. The result is immediate. No extra investment in purchasing of any equipment, can be done in the remotest of area. And as far as the randomized control trial of Barshi, what did it say? That VIA has reduced, by doing regular VIA, the incidence of cervical cancer can be reduced by 35%. This is not my statement. This is a result of the RCT Barshi project. So this test, which is very basic, has been completely neglected. But let me tell you, in my hospital, we are not doing Pap smears. We are not doing HPV. We are doing a VIA test. All our residents are taught to do VIA test. The nursing home, we have a cancer van bus. We have doctors doing a VIA, and they have been, empowered with an AI in VIA. I'll talk to it about later. And believe me, with this process, what happens is, if you screen the patient, it is aceto-white. You have a colposcope. You do a colposcopy. You see whether the colposcopy is positive or negative for CIN. If it is negative, your patient goes home. If it is positive, there and there you can treat her with cryotherapy or leads, whatever is feasible, available with you. So what happens is in a low middle, please understand, we are low middle income country. Please don't tell India is rich. Please, at no point, because that is not what the world looks at you. It is not what way. It's like मैं ही सबसे number one हूँ बोल के कोई फायदा नहीं है. दुनिया ने बोलना चाहिए तुम number one हो. So that is why we have to understand that we have to embark to this basic process. Do it for next 3 to 5 years and then think ahead what would be the best screening test. And VIA offers that chance for you. And it is not me, it is the Ministry of Health, Government of India 2016 recommendations that India should adopt to VIA based screening. So please, all medical colleges, go back to VIA, let your cytology clinics now be VIA clinics. And this is what the government of India has put forth. VIA, what to do if it is VIA positive, what to do if it is VIA negative, and how to, in countries like India, it is very important that if your screening treatment takes place in one go, in one visit for the patient, that particular process of screening will be very well accepted by the women in India, whether she is living in the remotest of village or she is one of the biggest doctors of the country also. For all women, if they have one method where they can get screened and they can get immediately treated, I think that will be very much acceptable to country like India. And that is why GOI has also said. So please remember, it is not just what we do in private is important. Definitely not important. Even I am working in the private sector. But what private does is not important. What the people in government do, what the people in municipality do, what the people in private do, all have to be clubbed together if we want to really achieve a cervical cancer Mukt Bharat, or for that any cancer, maybe a breast cancer also. If all of these three do not come together, then it is difficult to achieve all what is required. And we oncosurgeons are definitely going to flourish by doing surgeries for CA cervix. So that is the point I want to drive. It is not how much money my patient can afford or how costly my test a patient can afford. It is like everyone should be getting a single test, whether it is the poorest woman or the richest woman, then it will be an acceptable test. And just to get you to the point, that classification of South Asian countries by income levels, of course, now this was in 2019-20, Sri Lanka moves out. So the only country richer to us is Maldives and Bhutan. Rest, all we are within par with them. Again, with the BRICS nation, we are the last. South Africa, Brazil, China, Russia, far more ahead of. So there's enough evidence to say that we are LMIC. We are not rich. So somebody may ask me, are anybody countries doing VIA? I mean, I know these many countries, probably Saraya madam may know more countries doing VIA, but these are the countries which are doing VIA in the world as a national screening program, not as an individual thing. So countering all negative aspects of VIA, subjective observer variation now can be nullified via artificial use of artificial intelligence. And this will help patient to get screen, biopsy, colposcopy treatment and one visit. And that is what I spoke earlier is what LMIC requires. Coming to the last part of my talk. Artificial intelligence is the capacity given by humans to the machine to memorize, learn from experience, think, create, to speak, to judge, and make decisions. So what happens in this is lot of images of VIA are captured and they are run continuously on the machine. And the machine is given repeated chances to learn to associate specific patterns of the image and then develop a particular skill, so that it can interpret what that image is. And this comes from a lot of specialists. I've been a part of this project. A lot of specialists, give their input on what that image is, and then making the same thing, being repeated by machine. So what are the benefits? It is an automated guidance. It's an computer analysis. So subjective and objective analysis go fast, go away. The analysis is really quick and it helps in counseling the patients because you have specific color codes, and it reduces the monotony of analysis, because if you tell a healthcare worker that you do 20 or 30 VIA, after 10, I'm sure they are going to stumble somewhere in giving their interpretation of the result of VIA. So that monotony of the analysis is completely disregarded once AI comes into win, because it's a machine. It will, you give her 100 or you give her 200 pictures, it's going to give you the same analysis. So what is the advantage of these machines is what we do is we have a, just like you have a transvaginal probe, we have a small vaginal probe. So you put acetic acid and then you illuminate that acetic acid with this transvaginal probe and you'll get the picture on your tab. It is connected to a tab. So it is like a mini colposcopy. So you can understand, and then based on the findings, you have 3 colors: red, amber, and orange. So it will tell you, and green. So whether it is a negative lesion, whether it is at-risk lesion, or whether it is a high-risk lesion. So it will be told on the screen itself. You can even take images and give it to patient. It will help in patient counseling. It will help you in data keeping. It will help you in printing your results if required, sharing with experts. So a lot of things can be done with this AI based system. So it is called Smart Scope. Another one is this Smart Scope is as a part of Make in India project. It is the Smart Scope has been validated at 3 centers. One is Tata Memorial Hospital, one is Dinanath at Pune, and another is our hospital. The third phase is going on in our hospital, and we have more than 1,000 patients screened, and we are making a proper histopathology correlation. Remember, histopathology is the gold standard of cervical cancer screening project, and we are also in the one which was carried out at Dinanath. We are almost getting 100% of negative predictive value with this system, like the HPV test. So my hospital, Aditya Birla Hospital, is also a partner to this VIA-based AI-based VIA screening, including the International Federation of Colposcopy Cervical Pathology, and also including the Indian Society of Colposcopy and Cervical Pathology. So just this was of an anesthetist, 38-year-old anesthetist, where PAP said inflammation, negative HPV, and actually when we did this, we found a CIN1 lesion on biopsy, which was proved at biopsy. Of course, we have not done anything. She's on follow-up. But what I'm trying to tell you is, imagine this is the scenario of any women in the remotest of area or in the best of the area. You find this, this woman is not going to probably come back to you or be a part of your screening. You do a colposcopy, you do a biopsy, and at the same time you do cryo. Everything is one way. You don't have to depend on lab, because as a clinician, I am not at the mercy of my lab. Lab is just going to support or be a second fiddle to my clinical diagnosis. So what happens is the patient undergoes screening, biopsy, treatment in one go. And secondly, cervix remains in the hands of gynecologists. Believe me, we are losing cervix either to the radiologist or radiation oncologist, because nowadays radiation oncologists are saying even 1B1 and 1B2 has to be radiated. The only patients who can be subjected to a cancer cervix surgery is micro-invasive, 1A1, 1A2. So I guess we need to change these thoughts, and the take-home messages are, things are changing very fast. Guidelines, research are opening up new frontiers. In oncology, I think every year, I don't know whether Yogesh Kulkarni sir has joined, every year things are changing. And you cannot practice the same thing lifelong. Unlearning with relearning is the new norm. For postgraduate students, you need to know what I'm not included in this talk specifically because you have to go home and understand what is triage and what is its meaning. This has to be asked in your postgraduate examinations, and cannot go away without knowledge of cervical cancer screening or colposcopy. You cannot have a postgraduate degree if you have not done a colposcopy or if you have not done screening. And then there is no point in studying CA cervix if you don't know what is CIN 1, 2, 3. So this is a very important thing that all postgraduate, don't please study screening and cancer cervix, a big pre-cancer. And this is what has to be emphasized in all question papers that comes to you, pre-cancer lesions. Thank you. And I also have a chapter, the Foxy has released the postgraduate textbook in gynecology, and I have contributed my chapter on CIN. Please go through it. Thank you.
Thank you, Nikhil. That was absolutely wonderful, hard-hitting, straight from the heart. I mean, commendable. You have broken so many myths of ours. We felt cytology is the name of the game. Till now, even let's be honest, most of the consultants felt so, except that HPV came off and on as far as when we have a private practice booming with HPV reports and LBC. Now they combine the two, doing co-testing. VIA has made a re-emergence. I hope it stays and hope the students take this home. So also the consultants who have joined this program. Absolutely hard-hitting. My only question to you was, if you have to compare the sensitivity of VIA, not to the AI one, the non-AI one, with HPV, where does HPV score over sensitivity? And is the specificity also the same? Hello, Nikhil. Nikhil, can you hear me?
Yeah. Sorry. I had muted. You need to understand, sir. Yeah, I got your question. You need to understand two things, sir. HPV is always done by consultants.
Correct.
It is never done by junior people.
Correct.
Okay. VIA is also done by an Anganwadi and a healthcare worker. So if you have to actually compare, it becomes difficult to compare these two. When a healthcare worker does a VIA and you get a report versus when a gynecologist does a HPV in a correct method, obviously it is going to be a correct method. And most of the thing it is done by the liquid solution, not the method of collecting. So if you ask me very honestly, you cannot compare what a healthcare worker does and what a gynecologist does. It is just incomparable. But still, if I make gynecologists do a VIA and a gynecologist do an HPV, I think both will stand on par.
Perfect. Absolutely perfect. That's what I wanted to go across. I think people are just harping on doing a co-testing now in private practice, which just costs some amount of money. VIA should be the way out.
So, and screening, you are doing, remember, sir, you're doing screening, you're not doing any diagnosis. So if you're doing cytology also as screening, you're doing HPV also as a screening, then you're doing a colposcopy. So how much will you do for a patient? This patient then is not going to come to you for treatment. These patients will not, so that's why the precancers will not be picked up. Correct. It's like you are doing a CBC also, you're asking a ferritin test also, you are doing all the anemia studies also. I mean, you cannot do so much thing for a screening.
True.
That is where we are losing, that we are doing too much of testing for screening.
Nikhil, basically, you see, all of us agree that screening should be the norm. Every patient should be screened for cervical cancer. And it is the job of every gynecologist to do it. And this is where we falter. So once we assume this, that no screening should be done. Now the question is, now you made it very clear in your talk that now VIA is the way out as far as we are concerned, because it is see and treat. It's a one-stop treatment. It's a one-stop diagnosis and treatment, which is what our country needs. But the rest of the world is going the HPV way. So that is exactly what Manohar was trying to ask you.
But they are going the HPV way after having sincerely done cytology for 60 years. That's what I mentioned.
All right.
There is something as a national policy for screening. I mean, all of you know, a woman in US and UK, they get a call if they miss the screening test, right? And they are directed to the hospital. So now they are talking of HPV after doing their homework in cytology. We have done homework neither in cytology, neither in HPV, neither in VI. That's the problem, sir.
So in our country, this is the way out. And you know, HPV does HPV has a role in our country?
Oh, sir, I'm very keen that HPV has a role in this country. And my idea is very clear. I mean, there are a lot of youths in a lot of postgraduates. We should have an Indian-made HPV test. We don't want it from Roche and US and UK. I mean, I'm not the one who will take Western literature ahead. So let there be an Indian-based HPV DNA test, and all of you start doing it. It will work wonders.
Now, the message I want the students to carry home is that all of you should start screening for cervical cancer, whichever method you use. Now, you know, Pap smear has not died down in our country. So unfortunately, because the Pap smear has not died down, and these students are going to be examined by examiners who don't understand VIA but understand only Pap smear. So a few words on Pap smear as far as their exam is concerned may be in order. So would you do that?
Yes.
A few words on Pap smear screening.
What I will like all the postgraduates to understand is how to do a Pap smear. You should know the entire process, that it is an ectocervical and endocervical smear which has to be collected. You can put them both on the same slide. You need to stain it with 90% ethanol. The way you spray your ethanol, it has to be 45 degrees so that the cells don't get very badly washed off, and it should reach the slide should be properly labeled, fixed, and reach the pathologist on time with a complete history. You just, so if it is going as a screening, you can put it as a part of routine screening. Or if you're doing for a patient where you're doing it as screening because she has come to you with complaints, you have to write down the entire history. And all the postgraduate students, I would request you to go to your pathology department and at least see 5 slides of Pap smear before you enter your exam. You see how the squamous cells look. You'll see how the parabasal, basal, and the intermediate cell looks, and then go for the exam. because what happens is when you're reading the pap smear, you just read the report, which is incorrect. You have to understand what the microscopic finding is. And lastly, what do you say? Mild, moderate, and severe dysplasias is a completely objectionable and ill-defined method of reporting pap smear. Pap smear has to be reported by Bethesda 2014, I'm sure. I mean, I get Saraya madam correct me. It is Bethesda system of reporting. So you cannot have a pap smear report which says mild, moderate, severe dysplasia. That report has to be discarded. So once entire process is done, then a student is eligible for a postgraduate exam where screening can be asked.
Thanks, Nikhil. Just one more question. Smart Scope. Will it be seen more all around, or is it very expensive for an average person to have one?
In fact, we have just validated it, and I think there are more than 34 centers in India and abroad using it. So my hospital has also been using it. So we are using this only as screening. So what I can do is, in case AFG wants, we can have a small session on the process of Smart Scope as a part of physical conference where we can show all the aspects of it. Yes,
because it will change the
centers in all of India and across.
Because it will change the diagnosis and management of early lesions in a big way and help us to control cancer cervix in a big way, isn't it?
Well, everything will be under your control, sir.
Absolutely, absolutely.
It's empowering you to deal with your cervix.
This is perhaps the need of the hour in case you want to control our numbers. Anyway, thanks, Nikhil. Any other question, Karthik? Should we proceed further? I think this girl, so. Subhani has joined.
I don't know whether she's joined.
Subhani,
Smart Scope will replace the colposcope?
Well, sir, I'll give you a little political answer to that.
Okay.
We have to understand that Smart Scope, the intent is screening and not diagnosis. And colposcopy is for diagnosis. So what happens is, for some people, it may replace the colposcope who are not used to doing colposcopy. So how you can replace it? You do a VIA, you put in the Smart Scope, you take a biopsy, your lesion is defined as it is, and you get a picture of it also. So if you want to do a cryotherapy, based on the picture, you can do a cryotherapy there and there itself. But ideally, the cryotherapy and leads has to be colposcopy guided. So up to biopsy. So what you can do is for your patient is get your patient, do a VIA via the Smart Scope, take a biopsy. And if you have a colposcope with you, immediately take her on the colposcopy table and do your cryotherapy and send her home. And after 5 or 6 days, you will get a report of biopsy also. So everything will be done in one setting. That is what is happening in my hospital.
Okay. Thanks. Manor, we can go ahead with the case. You're muted. You're muted. Manor, you're muted.
Shubhani, are you there? Shubhani, I didn't see your name.
Yes, sir. Good morning, sir.
Good morning. We missed you a little early, so we went the other way around. We had the talk followed by your case presentation. So are you ready with your case, please?
Yes, sir.
Should we proceed?
Good morning, sir. Good morning, everybody. Today I'll be presenting a case on microinvasive carcinoma cervix. So my patient is Mrs. A, 40 years old, married since 20 years. She's para-4 living for
Will you go on the
resident of
slideshow, please? Shubhani, hello. Will you go on the slideshow? Yeah. Because we are seeing small images of this. You have to go on the slideshow, please. That's fine.
Yeah.
So
my patient is Mrs. A. She was 40 years old, married since 20 years. She's para-4 living for, resident of Dharavi and a daily wage worker. She came to our OPD with complaints of bleeding per vaginum after sexual intercourse since 3 to 4 months. These postcoital bleeding episodes are painless and they occur irrespective of her menses. No history of white PVD.
Can't hear you.
OCP or any
Yeah.
hormonal treatment in the last 6 years. Menstrual history of my patient. She attained menarche at the age of 14. Her past menstrual cycles have been regular with moderate flow. Her LMP was
The slides are not moving, Shubhani. She's gone off the radar.
Yeah, we've lost her. She'll probably join again. Nothing else we can do.
Nikhil, since we'll wait for her to join back, how often do you recommend the screening? You said if your VI is negative every 5 years or 3 years? Screen negative.
I think one of your slides said 5 years.
Yeah, that's right. Because I think the
Sorry, sir, I
recommendation
missed your
is
question. I'm very sorry, I missed your question.
when you have a VI screen negative, do you recommend repeating it every 5 years or 3 years?
So I guess it was incorrectly mentioned on my slide. It is not 5, it is 3.
3 years, yeah, that's right. And with HPV, they say 5 years, is it?
No, sir, 10 years. So if at
HPV
35, yes, if you have one negative test, that's what I said. It's a very high negative predictive value.
Great.
That's what I said. So if you do one test at 35, if it is negative, you repeat it at 45.
Because your FOXY guidelines say every 5 years.
Yes, FOXY guidelines generally
Yeah,
says 5.
FOXY is saying 5.
But
Yeah.
what I am quoting is from the WHO project and the Barshi project.
Shubhani, can you get us across?
hello.
Yeah, Shubhani, yeah, please get back.
Sorry. Yeah, so can you hear me, sir?
Beta, we can hear you, we can't see your slides.
Okay. Is this fine, sir?
Yes, seen now.
So her obstetric history, she is married since 22 years. Her age at marriage was 18 years. She's para for living for all vaginal deliveries. Age at first childbirth was 20 and she's not been tubectomized and no use of OCPs or IUCD insertion. There's no past history or any significant personal history. She belongs to the low socioeconomic status. On general examination, patient is averagely built. Her height is 150 centimeters, weight is 48 kg, BMI comes up to 21, GC fair, mild pallor present. She was vitally stable. CBSRS examinations were normal. On per abdominal examination, abdomen was soft, no guarding tenderness or rigidity, no organomegaly. Local examination of the external genitalia was within normal limit, no excoriation marks on the vulvar skin. On post-specular examination, cervical erosion was seen on the anterior lip of the cervix. It looked unhealthy and bled on touch. Vagina appeared healthy. On per-vaginal examination, cervix was firm to touch, uterus size was normal and bilateral fornices were free. Per rectal examination was unremarkable. Laparoscopic examination was done with acetic acid that showed acetoacetate white spots on the anterior lip at the site of erosions.
Shubhani, please wait. Shubhani, don't rush through. We got a lot to go back. Let's go back the previous slide, please.
Yes, sir.
Nikhil, you can also.
Nikhil, we need your participation in a big way. You said cervical erosion seen on the anterior lip of the cervix, unhealthy and bleeds on touch. What becomes your DD here itself?
So I was suspecting CIN or
कि थेपला बना है तो थोड़ा एक्स्ट्रा चाहिए थे तो लेके
My
जाना।
God, there's some crosstalk.
Huh?
Anyway, yes, yes.
तू जो बोलेगा वो बनाओ।
Navneet, you can, Navneet, please mute this number 854188.
Dr.
Yes, sir,
Suhani,
I'll do that.
before this.
Yeah, go back, please. Shubhani, go back. You're racing through. We will like you to go a little slow.
Okay.
Behind, back. Yeah.
No. You
No.
can start from per speculum before
First speculum, yeah.
Yeah.
So,
Okay. Next. So,
Colposcopic
Suhani,
examination.
Suhani, here I wanted to tell you. You see what was there. You have written PS, bleeds on touch, cervix was fine. And your next slide says you have directly gone to the colposcopy. Where your screening go? See, your next slide directly says colposcopy. Colposcopy is a diagnostic test. So what screening did you do in this patient?
she had an erosion out there.
Yes, sir.
So,
Two things. One, did you do screening first or no? And second, if you have directly done colposcopy, how will you justify doing a colposcopy without a screening when there is no obvious growth on the cervix?
So we had done colposcopic examination with acetic acid to look for acid-acid white spots.
So you did not do screening.
Yes, sir. So
Now let me tell you, come back to your next slide. You can justify doing colposcopy because what your answer should be, I have justified to do colposcopy because the indication of colposcopy, of doing a colposcopy as per WHO is an unhealthy cervix. So that is why I did not do a screening test. That's the answer. Are you getting
Nikhil,
it?
if-
Doing a particular test, you justify why you are doing it.
Nikhil, if she's used acetic acid, doesn't it become VIA?
No, she has done it under colposcopic guidance. VIA should be without any guidance. Once you get in a colposcope means you're trying to do a diagnosis, because currently we have not accepted colposcopy as our screening test. Go ahead. You can say I've done colposcopy in view of unhealthy cervix. That is still justified.
yes, sir. So colposcopy.
Okay. Shubhani, you've not answered Manohar's question. When you saw a erosion on the cervix, what came to your mind? What's the differential at this juncture?
So I thought it could be CIN because she was complaining of postcoital bleeding since 3 to 4 months. So I thought it could be CIN, or there was no discharge or anything indicative of a cervicitis. So I was thinking it could be CIN.
So just a reddened cervix, the first diagnosis here, and that means every erosion I see in my OPD, which must be almost 40% of cases of my OPD must be having erosions. Can it not be a normal hormonal erosion? She's just 40, right?
Yes, sir.
So let's say that it can be a normal cervical erosion. Then comes your DD. Okay, then is a CIN. Then what next? Rare ones also can happen. They are surprises in a big way after biopsies later. Anything else?
I think sir has already answered that. Sir, you have already answered your clue.
Rarest of the rare things, which even Nikhil, which I've been caught by surprise, even was once we turned out to be tuberculosis of the cervix. Can you imagine? It was all looking angry and bad.
Yes. And second is endometriosis of cervix, where you see these type of things bleeding on touch.
Go ahead. Colposcopic examination. You are among the fortunate ones to have a colposcopy in OPD. Wonderful. Go ahead.
So how did you do a colposcopy? Just let me know, what do you do at colposcopy examination? How do you do?
We take the patient in lithotomy position and we use a Cusco speculum. After that, we paint the cervix with acetic acid, and then we use the colposcopy to take shots of the cervix, to take photograph of the cervix that is seen on the screen on the monitor.
No. You are completely out of track. What I'm trying to ask you, what do you see at colposcopic examination of the cervix? What are the, what do you say? What anatomy of cervix
Okay.
do you see at colposcopy?
So there can be abnormal blood vessels.
I'm talking of anatomy, normal anatomy of cervix that you see at colposcopy.
So we see the os, the external os with
That you
the
can see without colposcopy. That you can see without the colposcope. So what is required is not just doing colposcopy. You have to see the original squamocolumnar junction. You have to see the new squamocolumnar junction. You have to see the transformation zone. You have to see which type of transformation zone it is. TZ type 1, type 2, type 3. And you have to understand what on colposcopy according to you is an aceto-white lesion. Suppose you have applied your acetic acid on colposcope. When will you say that this is a lesion if it is white? And when will you say it is not a lesion if it is white?
So the features of the lesions, they will have abnormal blood vessels and punctuations.
I cannot get it. What happens is, unless and until your eyes don't see the old and new squamous, see entire gamut of pre-cancer lesions, CIN1, 2, 3, A1, which you are presenting, 1A1 or 1A2, is within the TZ of the cervix. Everything is in the transformation zone. So that aceto-white spot which you have written is defined as aceto-white only and only if it is seen in the transformation zone. And transformation zone is something between the new squamocolumnar junction and the old squamocolumnar junction. So only and until you see the lesion in that, it is white. If outside this lesion, if you see a white aceto-white area, you will not take that as a lesion. Are you getting me?
Yes.
So all aceto-white spots are lesions only if they are within the TZ seen on the colon. That is the beauty of colposcopic examination. So you have to first define what is the original, where the line of original squamocolumnar junction is, where the line of new squamocolumnar junction is. You have to identify the TZ in the entire 360-degree circumference, then find the lesion in it, then see how big it is, how small. Now, I'm not going into further. You know what is sweet score?
No, sir.
How did you say it is a aceto-white area lesion? Just because your eyes found it white, it is white? Did you apply Lugol's iodine?
Yes, sir, after that. Lugol's iodine also showed.
So did you do any scoring?
No,
So
sir.
did you do any scoring for your colpos so-called lesion?
No, sir.
So kaise chalega? So there are two types of scoring. One is the older one, which is RCI, Read Colposcopic Index, which you can do. And now currently what we are using is sweet scoring for colposcopy. And there are 5 parameters in this scoring. And based on these, you have scores. So scores from 1 to 4, nothing doing. It's a low grade lesion. From 4 to 6, you have to take a biopsy. And greater than 7, it's a high grade lesion. Probably you'll have to do a leads to get your diagnosis. So it is not as simple as what you have written. Colposcopic examination showed this. There is too much of depth into colposcopic examination. Then only then discussion on squamous cell carcinoma will come. Go ahead.
Cervical biopsy was taken from the suspicious area that revealed squamous cell
How did you
carcinoma.
take biopsy? Wait, how did you take the biopsy?
So cervical punch biopsy we took.
Yeah, but you did it with under colposcopy guidance, or you did it with a naked eye, or you did it with what was looking?
Naked eye from the site of erosion.
Then why are you using colposcope? All biopsies, if you have a colposcope, should be colposcopic directed so that it is accurate. Now, how much specimen of that biopsy did you send to the histopathologist? What was that size of the specimen of the biopsy? You know what? As per the American College of Pathology, you are not supposed to report the biopsy of the cervix if it is less than 6 millimeters. It has to be inadequate. If your biopsy specimen is 1, 2, 3, 4 millimeter, the pathologist have to put it as inadequate. It has to be 6 millimeter or more for them to report, because after all, you have to see a breach in the basement membrane. So if you give a very superficial chunk, how will they find a breach in the basement membrane and how will they show microinvasion? Because you have put 3 millimeter of depth of cervix. For 3 millimeter of depth of cervix, in fact, your specimen should be at least 8 to 9 millimeters. So what was the size of your biopsy?
Yes, sir. Sir, I'm not sure.
And second, please understand, lymphovascular invasion cannot be seen on biopsy. If you're giving an oncology examination, this won't be tolerated that you're putting on biopsy whether lymphovascular invasive space involvement is there or not. It's okay, you're doing an OB/GYN examination, but a small specimen of 4 millimeter, 5 millimeter biopsy cannot tell you about LVI. So please take off this word from your this thing when you're presenting it in your exam.
Yes, sir.
And also, how will you take the biopsy specimen? So what all will you include in that biopsy specimen? I'm not sure whether I'm clear or not, but when you take a biopsy specimen, which areas would you take?
So from the transitional zone involving, sorry? Sir, you are not audible.
Karthik sir, please unmute. Sir, unmute yourself.
Okay. Okay, you found the acetocyte area in the transition zone at 6 o'clock. So which all areas will you take for biopsy? I'm not sure whether I'm making sense to you, but make an attempt to answer. All right. Basically, what I want from you is you will take a part of the normal looking tissue along with the abnormal tissue. Is that correct, Nikhil?
Yes,
Yeah, it's always better to take a deeper biopsy. That's what, in fact, sir, what you're telling comes in the criteria of biopsy. So when you take a biopsy, if you take a good 8 millimeter to 1 centimeter of biopsy, the pathologist will also get the normal tissue with it. And let me tell you, there are good Tischler biopsy forceps guns, which are now very cheap and easily available. Believe me, invest in that. And it has such sharp edges that it is, and that hole itself is 8 millimeter. So in one setting, you'll get a very good crush of the biopsy of the cervix. And remember, when I take a biopsy, I give patient pause for the next 2 days. So a superficial biopsy will never bleed. When I take biopsy, all my patients have little bleeding that they have to take pause for 2 days because my biopsies are really deep, because I am worried that if I give an inadequate specimen to my pathologist, I'll have to call the poor lady back again. So my first biopsy itself is very good, deep, and it causes certain amount of bleeding. Then the biopsy specimen is okay, and then you'll get a very good histopathology report also. Please go ahead.
Yes, sir. So my case summary. Mrs. A, 40 years old, married since 21 years, sorry. Para for living for with low socioeconomic status, complaints of postcoital bleeding. On examination, cervical erosions with on the anterior lip of cervix that stained acetoacetate white with acetic acid, and biopsy was suggestive of SCC of cervix.
So what other histopathological types of cancers?
So it can be a squamous cell carcinoma or
in this case is squamous cell. Agreed. So what are the other histopathological types that you are aware of or you know?
so large cell keratinizing, small cell keratinizing.
Is the all part of squamous cell only?
Adenocarcinoma.
Okay.
And adenosquamous carcinoma.
What do you mean by adenocarcinoma of cervix?
Adenocarcinoma, so there will be adenocarcinoma is any carcinoma, mucin producing cells will be there, so columnar cells with mucin producing.
But squamous cells is in the egg. So where does it come from? Where does it originate?
Endocervically, mostly adenocarcinoma mostly arises endocervically.
Endocervically. So will your colposcopic examination help you find an adenocarcinoma?
No, sir. For adenocarcinoma, usually a cervical sampling has to be done. Endocervical sampling.
Endocervical sampling, correct. The other way is during colposcopy, we also have something called as endocervical curate. So that endocervical curate opens the internal os, and then you are able to visualize the entire internal os right up to the the columnar epithelium. So you can open up the blades of the endocervical speculum, put acetic acid there. You can see the acetowhite areas there. You can take biopsies from inside. If you are not able to take biopsies from inside, then you can do a very good endocervical curettage. Fair enough. Any other histopathology variant you know on the cervix?
It can be a combination of both. Adenosquamous type can be there,
Okay.
and neuroendocrine tumors can be there. So melanomas can occur
Yes.
in cervix.
Fair enough. Go ahead. Fair enough. Go ahead.
Undifferentiated variants can be.
So what do you think is the cause of squamous cell carcinoma in your patient?
So she has many risk factors, like she was married at a young age, increased number of parity, and increased early age of first sexual contact. All of these increase the chances of HPV infection in the patient. And because of low socioeconomic status, she is more likely to have poor nutrition, poor immunity, so which later the HPV infection persisted to cause.
Very good. So the HPV has to be the primary cause of causing cancer cervix. And what you mentioned, multiparity and other things are cofactors to it. And remember, just having HPV-16 should not scare anyone. It is the presence of these cofactors which help this HPV to multiply. And you remember that HPV is there in every cervix. The more and more micro trauma that occurs to the cervix, either because of menses, intercourse, IUCDs, handling of the cervix, this is probably responsible for causing the HPV to multiply and cause cancer. So repeated micro trauma to the cervix is the reason why HPV proliferates and goes ahead and forms cancer. Okay, fine, good. So now just come back to your diagnosis, your conclusion, your summary.
Yes, sir. You have written with biopsy suggestive of now when you talk of cancer, then what is your stage? So it's stage 1, sir. Stage 1, 1A1.
Why?
So because it was a microscopic lesion and it wasn't visible to the naked eye as a proliferative growth. And
do you know the stages of, I don't know whether you should be asked or not. Do you know the stage of CA cervix?
Yes, sir.
1 to 4.
Yes, sir. Stage
What?
1 is involving the cervix and less than 5 mm depth of lesion.
Doctor, I wanted to know, you need to know that we are 45G of figures. And since you are presenting the case and now you are in 2022, you should also understand as revised the stage. So are you aware about that?
Excuse me.
Sorry, sir, I couldn't hear, sir.
Please, yeah, who is this?
Priyanka in. Somebody
I
Priyanka
have
in.
muted them.
Yes, sir.
Okay, so Suhani, you have to understand one thing. You will be exam going in coming years. So FIGO is the classification or staging that we follow. We also follow TNM staging, but currently everybody is following FIGO. And FIGO has revised the classification of all gynecological cancers in 2018. Our
Yes, sir.
very own Dr. Nija Batla, who is the head of Department Gynae Onco AIMS, has been a part of this revised staging of all the gynecological cancers. So are you aware of 2018 staging?
Yes, sir.
of what is it?
So in 2018 screening, the stage 1 is cancer involving the cervix, disregarding the spread to uterus. In that, the lesion has to be within 5 millimeter. In that, the maximum length. So in that, the maximum depth of the lesion has to be within 5 millimeter. That is stage 1A, in which stage 1A 1 is within 3 millimeter and stage 1A 2 is 3 to 5 millimeter.
Yeah, correct. So we have nothing to do with the depth. The depth is gone. Okay. So now tell me one thing. Are you happy with a biopsy report of SCC? So will you say that this is enough? Is this your end, that you have taken a biopsy and the biopsy says SCC and it is a micro-invasive, that is stage 1A, whether it is 1A1, 1A2, we'll come to it later. But is a biopsy adequate because your biopsy was a punch biopsy forceps? Doesn't it come to your mind that if it is on a punch biopsy, you're getting this report of a squamous cell, I'm seeing a very small 3 millimeter thing. Could it be more than this?
Yes, sir.
So what? So let me tell you, your biopsy is identifying a micro-invasive 1A1 type of a lesion is not correct. So what will you do? What will you do to reconfirm the diagnosis of this patient? On biopsy, micro-invasive cancer, unacceptable diagnosis. What will you do?
We can go for imaging, sir, to see if there are
Ooh, come on.
clinical.
Please don't talk about imaging in front of me.
Please.
Your gynecologist,
please.
PS, PV, PR tells you everything.
So a detailed clinical examination did not show spread to parametrium or there was
No, that's fair enough. You have probably not mentioned that on PR you did not find a parametrial invasion, rectal mucosa, POD. Fair enough. Okay, but okay, let me give the answer. The idea is micro-invasive cancers of cervix are diagnosed only on specimen of leads. So for this patient, a biopsy is not enough. You have to do a large loop excision of the transformation zone. Then only you will come to know what is your depth. Okay, so 3 millimeter on a punch biopsy is not acceptable. So what you should have done is, once you know it's a very high grade lesion, or so that's what I said, you have not done a scoring of colposcopy. What your lesion is there, what you have written after colposcopic examination biopsy, you shouldn't have done biopsy there. It is a high grade lesion there because you are now talking of a presence of SCC. So that is why at that point of time, it has to, leads has to be done and not a biopsy. So all the postgraduates have to understand that micro-invasive carcinoma of cervix is a lead specimen. And that is why in examination, if you have management of 1A1 or 1A2, the examiners want more you to talk more on colposcopy, more on leads, more on transformation zone, more on the depth, more on 1A1 and 1A2. Are you getting me? Then only your diagnosis is confirmed. So micro-invasive cancer of cervix is a diagnosis of a lead specimen, and that is why you get 1A1 and all the students get FOX, because you hardly talk about colposcopy and leads. And that is exactly what we want, and that is what is exactly expected from a gynecologist. Got it? So your next step would be leads.
Yes.
What is leads? How you do it? Any idea?
I have never. So there's a loop. A loop is used to excise the segment of the cervix, the unhealthy segment of the cervix, and that segment is sent for biopsy.
Okay, I guess you probably read about it, go through the videos. But the answer to is leads. And many times, please understand, if it is a pure 1A1 on leads also, and if the margins are clear, it becomes a treatment also. So leads is the treatment also for CA cervix in 1A1 grade 1. So your treatment is also done if you do a lead. So it serves both the purpose, diagnosis and treatment. Also in very selected cases of 1A2, leads is the treatment. Are you getting me? So leads is serving. So this is what we are expecting. See, your gynecologist, we don't want you to know Vardheims or do Vardheims. We want you to know this. We want you to know these concepts that even in 1A1, if you do a leads and if the margins are free, you have done a good job, your treatment for 1A1 is done. By the way, what did you do for this patient?
So since she had, she had completed a family. She was 40 years old. We asked her if she is willing for hysterectomy, and she was. So we went for a simple hysterectomy.
So, but then in that case, remember one thing. Now, when you have a diagnosis of squamous cell carcinoma, before hysterectomy, did you do anything to understand that it was only restricted to the cervix, or it was micro-invasive and it was not micro-invasive, or it was not spread anywhere?
That we had done an MRI.
What did you do?
MRI. We had
MRI of what?
MRI abdomen pelvis to look for lymph nodes, if there are any lymph nodes, and spread to the pelvic wall or parametrium.
Okay. So you did an MRI. Anyway, that's fine. But let me tell you, MRI does not pick up lymph nodes. So if your intention of doing an MRI is to find lymph nodes, that's again wrong. It is CT which picks up lymph nodes, which picks up metastatic disease, which picks up peritoneal disease, which picks up adhesions and everything, and not MRI. Probably MR will only tell you about cervix, parametrium, vagina, which you can actually even access by a good PV and PR examination if you do a good examination under anesthesia. Anyways, you have done a imaging. You said that it is the what was your report of histopathology after removing the uterus? You should have posted that report. After hysterectomy, what was your report?
It was suggestive of squamous cell carcinoma, and that was
what squamous cell carcinoma. It will be a deep. Now the things come: lymphovascular space involvement, neural involvement. Because if it is a cancer, the histopathologist automatically writes these points. Then depth of invasion, how much millimeter, basement membrane, everything comes. So what was it? Did you remove ovaries in this patient?
no. In this patient, no, sir.
Okay, why?
Sir, she is 40 years old and squamous cell carcinoma of cervix very rarely metastasized to the ovary.
So you don't know what is your final histopathology report? See, the entire process of pre-cancer and cancer is pathology based. We don't require imagers. We require good pathologists. It is the pathology which is going to decide the future of that patient. So it would have been great if you would have posted the complete detailed pathology report of this patient. That's only would have confirmed that it was actually 1A1, 1A2, because again, if it is 1A2, then you have to think for the lymph nodes also. So at hysterectomy, how did you do the hysterectomy?
So it was a...
I think, Nikhil, we can take the hysterectomy for the second case. Yeah. We have one more case to go.
Yeah.
Okay, we can go back to the next case. I was not knowing the time, sir.
Nikhil, just a minute. Before you proceed further, we recognize the presence of Dr. Usha Saraya, who's been with us, and Dr. Yogesh Kulkarni, you have just joined. Just to update you, this is the case of microinvasive CA, which this Dr. Shubhani is presenting. In case any of you want to add something or ask a few questions, because Nikhil has covered enough ground. And in case either of you would like to put in your opinions, suggestions, or questions, please. Yogesh, can you get me?
Yes, I
Yeah.
can hear you. So I was just
Because
listening, sir. I think
Nikhil has covered great
it's-
ground already. So in case you
Yeah,
want to
yeah.
give your inputs, something which
No.
she has missed, because now we are on the specimen. Yes, Shubhani, you can wrap up with your final discussion on the specimen as Nikhil has asked you. Shubhani, are you there?
Yes, sir.
Yeah,
Yes.
so Dr. Nikhil has asked you a question.
So histopath report.
Yep.
No, sir, I don't know the exact histopath report of this patient.
Okay.
Okay. So, shall I say something, Dr. Motwani?
You must, ma'am. We need your
Yeah.
words.
No, first of all, Shubhani done very well answering all these questions, because I know this doesn't become a part of their training also, and we all have to learn how to handle these cases, and very few people go stepwise, like Nikhil has said. And I realize that it's so many steps are involved in coming to the final diagnosis. So all in all, she has done very well, and I think we will, if they were to do a colposcopy course, then only they will learn all these things that Nikhil has talked about, because otherwise they don't learn. Then this correlation with pathology is lacking in our medical colleges. I don't know about other institutes, but the pathologists and the gynecologists don't sit together and discuss anything like that. And our students don't have exposure. And that is a lack in our training, I think. And we are very conscious that we must have the full histopathology report. We must correlate the findings. We do all cytohistopathology correlation and see where we have gone wrong. So these are little specialized things which we will pick up as we go along, and we are just beginning to start our screening and treatment process. So I think this is a very good attempt done by AFG also to bring in all these things, and for the young student who did it very well, I must say. So congrats to her, and congrats to Nikhil for making her aware that there's so much depth in this subject. Yes, Yogesh?
Yes, ma'am. Yeah, I totally agree with you, madam. You know, most of the times, as a part of our training, we do not have exposure to colposcopy and the related things. And I think it's absolutely vital, because as gynecologists, we are the primary service providers. So if we miss out on something, it's very likely that the patient will be missing out on the follow-ups. And so I think all the residents must understand the importance of evaluating a patient in a stepwise manner, be it a pre-invasive lesion or a cancer.
Yes, and pre-invasive is going to be more of a challenge, because it is asymptomatic, young patients. We have many issues. Thank you.
Shubhani, one final question. How will you follow up your patient? And for how long? Shubhani, are you out?
Yes, sir.
You have done a hysterectomy. How will you follow up? How long?
Monthly we'll follow up her for first year. For first year, 3 monthly, and after second and third year, 4 monthly.
What will you be doing on her at that time? What are the recent guidelines regarding follow-up of patients who have undergone surgery for microinvasive CA? You have done a hysterectomy on her. Do you need to follow up these patients? How will you follow? We said frequency first 3 monthly, then 4 monthly.
Cytology, we can take a cytology, wall smear, and then.
Yes, Nikhil, your final words on this?
I will be covering that in my lecture, the follow-up of CIN.
Okay, great.
I know
Chalo,
it's not.
Shubhani, I think, Shubhani, you have taken a lot of things from all of us. Thank you.
Thank
you. Thank you, Shubhani. You have done well.
Thank you, sir.
Well, I think with the case and talk being done, now we have among us Dr. Usha Saraya. In fact, you can identify cytology and remember Dr. Usha Saraya right from a student day. She's been a teacher of teachers of teachers. You know, generations have been have been going on, who have been taught by ma'am till now. And I was a student in MBBS and MD in my late 70s, early 80s. Dr. Usha Saraiya was, that time used to talk on cytology. And this is how it all started in 1970, a love for cytology. Can you hear me, please?
Yes, yes.
Yeah. So she started a cytology clinic at Kama Hospital in 1970. And over the years, she nurtured it. And she's given it an international recognized center today. We'll have to mute this gentleman, whosoever he is. My dear friends who are on the program, please mute yourself. It's distracting to the speakers. Please do us a favor.
Just one minute.
Madam Usha Saraiya is so active even today that she's practicing OBGYN also. She's attached to Breach Candy, Saifi, Elizabeth, and she has been conferred with awards which really are really huge. Internationally, she has been conferred the Honorary Fellowship by RCOG in 2012, Award of Living Legion by the International Federation for Cervical Pathology and Colposcopy called IFCPC in July 21, very recent. Leadership Award for Preventive Oncology by SAFOG in 2022. That's the latest, I think, madam has been conferred with. And she national award, she has got a Lifetime Achievement Award in AOGIN, that is the Asia Oceanic Research Organization for Genital Infections and Neoplasia, 2017, for Lifetime Achievement Award 2020, but the list is really endless. It's such an honor to have you, madam, amongst us. So very thankful and grateful to you for being with AFG today morning. And we would love if you continue a little longer with us, but you have a commitment at 12, you told me. So we are eagerly waiting for your talk on recent trends in the management of CIN. Over to you, ma'am.
I see. Thank you so much. I thought Nikhil is speaking before me. Isn't that right?
Nikhil's talk is over, ma'am, because we finished off much earlier. Yeah, we started
Yes,
because we swapped it. Nikhil spoke first and then we had the case.
Okay. That's fine. Then I'm ready with my talk on recent advances in the management of CIN. First of all, I want to thank AFG for this opportunity to come and talk to you. I have known AFG probably from its inception, and I have worked with AFG and given talks to their speakers, to their members. And it's my pleasure to be here to talk today on the management. And if Nikhil has already spoken and discussed the screening, then we know that there are going to be a lot of patients who will come to you as screen positive, means something is found on screening. Screening is only a screening test, doesn't give you the diagnosis. It is up to you to find out. So we need to be aware what we can do next when we get a patient off with a report which is screen positive. So the treatment to provide appropriate management of pre-invasive lesions so that the sun can finally set on invasive cervical cancer. That has been our aim, and it is still to some extent an unfinished agenda, as we realized just now when we discussed a case, that there's so many things we need to understand. So when that patient comes to you with that screen positive report, she's already traumatized if somebody has told her that something is wrong with your smear and you have something abnormal. So don't alarm what is this noise?
Madam, please, there is somebody distracting.
Okay, not to alarm the patient and family and that she's got already got a cancer or she's likely to develop cancer. She's already traumatized. So just reassure her, nothing like that has happened.
Madam, 1 minute. Madam, there is a distraction by Sonam Vishwakarma. Sonam, can you please mute yourself? Sonam, please. My friends, all my friends out there who are listening to the program, We request you with folded hands, mute yourself. Let only the co speak. Please. This is not done.
Acha. Okay.
Please go ahead, ma'am. Yeah.
So give her proper assurance that proper treatment at this stage will prevent any such eventuality. I wouldn't like to use the word cancer myself in as far as possible. And treat the patient as a whole. You're not going to treat only her smear report or something like that. And you have to individualize her treatment in consultation with the husband and the family after knowing the protocols very well yourself. Because we have to take into account her desire, her social and economic condition, and what is available in her own geographic area. You can't send her far away. So our motto remains enlighten, but don't frighten. Now we have certain principles of management. You emphasize that nothing is going to be solved immediately. You will need supervision. You will need observation for 2 years. Be mentally prepared for that. And do some co-testing. I know that co-testing is not routine in our protocol. We don't advocate it. It's expensive. People don't like to do too many tests. But later in the talk, I will explain to you why it is important. Because even patients like a reconfirmation of the report. Otherwise, they say, can we go to another lab and get it tested? Maybe this report is wrong. So, we have to satisfy them. And of course, there are very special groups. If it is an adolescent girl or a very young girl recently married or something, pregnant women, then immunocompromised persons, and those who have other health conditions. We have many young girls with other health conditions, and then they have this problem also. And we don't know how to treat both conditions together. And remember, patients' reaction to diagnosis of CIA is fear. 100% fear that they are cancer patients. So we have to really spend a lot of time doing some counseling on this issue. Now, then you find out in what category is your patient. Does she have only infection with HPV, or does she have a low-grade lesion, ascus, something which we know is reversible and we have to work towards reversion? Or does she have a high-grade lesion in which we don't have too much time to waste? Or as we saw in the last case, she already has reached the microinvasive or occult invasive lesion, then management is different. And does she have any associated pathology? Now here I'm showing you my social worker who's taking the history, who's interviewing the young patient. She has only one child. She has come with her mother. And we try and get the fear out of her and convince the family that she will be treated and she will be fine and she will be able to complete her family. And on this side, you can see a very good histopath report of the biopsy, which showed a carcinoma in situ or a high-grade cyst on the surface, and endocervical gland extension is also seen. So, a lot of information we need when we try to treat the patient. So if it is just HPV positive, and now with all of us wanting to switch over to HPV testing as primary screening, you will get cases of HPV positive cases without any lesion on the cervix, without any symptoms. And we have to tell them HPV is not really a disease. There are no symptoms. And it may be a carrier state for many years, but suddenly it can get activated. It is usually sexually transmitted. This is very disturbing news to the family, but it is not a sign of infidelity, or it is not something which should break up a happy family. Both partners need examination and treatment. And HPV has relevance only to cervical cancer screening. Otherwise, as such, we are not concerned about it. So HPV is common, about 10% in any most populations, but the cancer cervix is very rare in HPV, only 1% of the above 10%. So they do need care, they do need supervision, but it's not as if it's definitely going to happen. And good immunity will eliminate HPV infection within 2 years. This has to be remembered, and we must work towards eliminating that virus. Now, if it is ascus and low grade, you know, you're going to keep her under observation. You're going to say, come back and see me after 6 months or 1 year, whatever you want. But doesn't mean you don't give any treatment during that 6 months to 1 year. You try to improve her general health. If she's anemic, you treat her, you give her folic acid, you give vitamin deficiencies, you treat. Vitamin A, E, and D are all important for epithelial integrity. You know, the nasal epithelium also requires vitamins. The conjunctival epithelium requires vitamin D. So we know that the epithelium requires these drugs, and we must give them. Discuss what contraceptives they are using. And barrier is the best contraceptive for this condition. Then smoking and use of tobacco in either partner is sometimes a cause, and we could advise regarding that. But as a gynecologist, I really appeal to you to give treatment for lower genital tract infections if they have. Many of our women have persistent and consistent lower genital tract infection, and they ignore it. But remember, cellular immunity is highly susceptible to carcinogens. If cellular immunity is down because it's fighting fungal infection, like the picture you see, and the cells become abnormal because of infection, and they are susceptible to get a carcinogen right inside the epithelium. Now, what choice do you have for treatment? I want to tell all of you again that all this is 21st century medicine. In the 20th century, we didn't have these methods, and it was not known how to treat so well. But today, Foxy GCPR is available to all of you on the web, as a booklet, as a CD, as so many ways it is available to each and every person. So that will give you what is the management of pre-invasive lesions of the cervix and how to manage these cases. So first of all, there are methods of ablation. Secondly, there is excision. And if you want to do both ablation and excision, that is also possible. So for ablation, what do you have? You have cryotherapy, in which that abdominal area on the cervix is frozen with nitrous N2, nitrous oxide, the gas, or you have something new which is called thermocoagulation. Now, the problem with ablation is always that we are doing something without a biopsy correlation. So it need not be like that. You are free to take a punch biopsy before you do this procedure. So you can combine. If you feel you want to do a biopsy, by all means, take a biopsy and then do ablation, whatever you want. And we are giving permission, very liberal permission. Foxy GCPR says that if you don't have any facilities, just treat with ablation. Now, if you want to do excision, it's very good. You have the LETS, which I think Nikhil has already talked about, LEAP procedure or LETS procedure. I will show you what it involves. It removes a large part of the cervix. Or if you don't have the LEAP procedure, no problem at all. You can still do a simple cold knife conization, CKC WHO calls it, which we have been doing for years. Requires no equipment except a pottery machine, perhaps. And it has the benefit of biopsy. You can do immunohistochemistry. You can study the basement membrane and where it has reached, breached, and of course, lymphatic invasion you come to know right away. So staging is possible after LETS. If you want to do both together, it is possible with a CO2 laser. CO2 lasers are there in Mumbai city. They are available in all major cancer hospitals. The ENT surgeons use it liberally, and you can have access to it. It's not difficult. You can organize it. So let me talk to you first about cold knife conization. Any gynecologist, MBBS, DGO can also take up this procedure and do it very easily. You don't need much. You need to be ready to do the DNC. You have to have acetic acid, or you have to have at least Schiller iodine, and you paint the cervix with Schiller iodine, and your circular incision on the cervix has to go little beyond the iodine negative area. This is what Dr. Motwani was saying. We want to take a little bit of the normal area when we take the biopsy so that we compare the normal and abnormal. And the cone goes right up to internal os, but not include the internal os. The internal os should stay intact. We don't want to damage that sphincter at all. And just below that, you can come and you take a big cone or a small cone or whatever your indications are. A small cone causes less problems and big cones cause more problem. And if there is brisk bleeding, you cauterize everything. And even then bleeding doesn't stop. You can put in gauze piece or a roller gauze and pack the site of the operation, and it stops in 2-3 hours. It will stop, and we do observe the patient for at least 5 to 6 hours before we send her home. Bleeding should stop. It should not be a major issue. If it doesn't stop, you may have to admit her occasionally, and it will stop the next day. Now I come to cryotherapy. This is very important because this is our mainstay. At the moment, the mainstay is cryotherapy. Liquid nitrogen is used to destroy the abnormal tissue. And you can see here this blue cylinder. That cylinder is very big and heavy. You get smaller ones nowadays, but you have to have it around with you for that procedure. And what it does is it causes cryonecrosis, dehydration, vascular stasis, and protein denaturation. So that whole abnormal epithelium is totally destroyed under your own eyes and it forms a ball of ice. But we don't do it once, we do it twice. When you see this ice forming around your probe, you switch off the gas, the liquid nitrogen cylinder, and you wait. Don't try to pull the swab. It won't come out, it is stuck, and you will cause damage. But as the temperature changes and as the thawing starts, the probe will come out easily. Then you wait a little till the thawing is complete. Then you apply again, second freeze and thaw cycle. So 30 minutes is minimum that you take because you have to wait in between for 5 to 10 minutes. No anesthesia is required. Now we have new instruments called cryopen and cryopod, which I have seen but not used. And you can do 10 cases at a time because it has a very long probe in which enough nitrous is saved to do 10 cases. So that cylinder you can do without for at least for 10 cases. But it's not yet approved by WHO, so I'm not giving you much information about it. Now you see, this is the second time now this cervix is thawed, and now we are ready to do it again. And this is the probe that you have. You keep the probe on a sterile piece of paper and use it the second time. Let the patient relax. You can give her something to drink and make her legs down. And it's not lithotomy, we were talking about that biopsy also and the colposcopy. It's not lithotomy, it's really the dorsal position that we use. We don't have to put up stirrups. If you can put up stirrups and patient is comfortable, it's okay, but dorsal position is quite enough. And then this is frozen, the cervix and the lesion, and she can go home the same day. Now, if it is high grade lesion, or it is a persistent or recurrent low grade, that is also very significant. You get a low grade, you treat it, 1 year later she comes back and again she has the lesion. That is called recurrent, and then you have to treat her some more. Now, this is excisional rather than conservative management. High grade, you do require excisional rather than conservative. But if you read our FOXY GCPR guidelines, they will tell you you can do conservative with cryo and thermo, even for high grade at the moment, because you're not, patient is not able to go to a higher center, or you are not able to organize the leap, and you can keep under observation, and you may postpone the leap for a later session. You know, these are slow growing tumors. So do the best that you can is what we are trying to tell you. We are trying to tell you to compromise, not to for the sake of compromise for your sake, but the compromise for the sake of the patient. Don't let her go away without any treatment and lose her. You do what you can and keep her under your observation. That is important. And you know, this leap specimen gives you a lot of information. Apart from what we said earlier when we discussed the case, it will tell you how much is the invasion, how much is the area of abnormalities, is it a small area, big area, is there microglandular invasion? That is very, very important question. I'm coming to that in a little while. And we have now immunochemistry to actually locate the HPV positive abnormal areas and things like that. So I feel this knowledge of HPV and the microinvasive lesion and what we are doing, it's all still evolving. We are getting to know more and more tests to do this. So this is the loop that you are supposed to use. It's Prendeville's loop for excision. And Cartier, many, many years ago, used to come to India. He's come to Kama Hospital several times, and he's shown us how to do small biopsies. Instead of punch biopsy, he suggested you do the loop biopsies, which are better and doesn't give that burning effect in the specimen. And you can, Prendeville has given lots of choices of loops. You can take them and you can do a very good leap procedure and remove the abnormal area. Now, this is under colposcopic guidance we will be doing, and we have this whole area of abnormality which we have already located with acetic acid, and we are going to take one big loop and sweep from left to right or right to left. And if you want to do up and down, you have to go from down to up, not the other way around. Then we have this cold coagulator of SEMS, and I'm only showing you SEMS picture with me because many of you will remember Kurt Sem. He was a regular visitor to Mumbai. He has taught us endoscopy right from the beginning, and he used it for radical ablation, the cold coagulator. Somehow he was interested in all this, and he had some techniques. But it's a misnomer. It is not cold. It is heat only. And it is a very good OPD procedure, and it is used a lot in UK. So now this is the modern. It's not called SEMS any longer. It's got some other companies, and it is available for you in India. It is low cost. It is portable. It is lightweight, battery operated. Cervical ablation can be done very easily. Autoclavable probes are available. You can see whatever size you want for the cervix. No external power supply required during surgery. So you can carry this box to the camps and use it at the camp level. I think that's a great progress we have made. And this is how you attach it to the cervix and give just a fraction of few seconds you require, and it gives a depth of necrosis at 100 degrees centigrade at up to 3 millimeters. So even a little bit of the breach of basement membrane, it will be taken care of. I think this is a wonderful equipment which we are about to get right now and get our own experience with it. But you can see these are all very new gadgets. Then CO2 laser is an old gadget. I've used it in Harkishan Das beginning of this century many times. It's electromagnetic radiation. Energy is converted into intense heat and cells are just destroyed by explosive evaporation. There's no tissue debris, cervix looks perfectly normal, complete hemostasis. You don't ever have to worry about CO2 patient, CO2 laser patient bleeding, and very, very rapid healing. So I feel we must remember this method and find out institutions where they have a laser, CO2 laser, and collaborate with them. They'll be happy to take our cases. So this is what Linda Quinn said in 2009, that's a long time ago, that several techniques are in use. All these techniques are just being used. No single technique is superior. All techniques require colposcopy. Now, you know, this is a requirement we cannot satisfy. We cannot tell everyone that you first do colposcopy and then do treatment. In doing all that, the treatment may get forgotten or not done. So, but special training is required, that I do agree. You have to have a little training in all these techniques before you start using them. It's not difficult. And I'm showing you here the portable colposcope. So if you say all techniques require colposcope, it will be possible when we get this like a mobile phone colposcope. Can you see that? And this you will do in your clinic and you can start doing any treatment. So colposcopy, as Nikhil said, is a diagnostic procedure and not screening, but times are changing and very soon you will have colposcopes which can be taken to the village. Colposcopy will become a screening tool also when all this happens. Now, what do you want colposcopy to do if you say colposcopy is required? It is the ideal method to diagnose HPV lesions and CIN, and you are getting a direct assessment by the clinician of the entire female genital tract. There will be HPV lesions in the vagina and in the vulva, which you cannot see with naked eye, but you'll see it now. Then you'll differentiate low from high grade by colposcopy. You don't have to wait for biopsy report, and you can decide whether to do ablation or excision for that particular patient. I think this is a very, very important step which we can take, because every time to wait for biopsy and then to do a leap and all that just delays treatment. It's very valuable also for follow-up. And you give comprehensive health care, you know, treat anemia, STD, contraception, that I'm telling you, you can never get rid of, but it requires some level of training. By colposcopy courses are done by FOXI. FOXI has something like 20 centers recognized, and it's a 3 to 4 day course. It's not much, and it's very simple to learn for everybody. Now, what are we going to do for India? That is our major problem. We want to eliminate cervical cancer. Is that possible? Not possible. There are many people who say, don't talk of the impossible. Why are you wasting time? We need cancer detection centers in all districts. We have 782 districts. So all our young doctors, I hope, will take up this topic and go to the district level and work. Women's health issues, we have yet to solve many. Follow-up is important, and how to refer to cancer hospital is our next problem. I'm coming to all these issues. And I don't want to talk about this picture, but I hope all of you have seen it. This is at FIGO when the announcement was made of elimination of cervical cancer. And FOXI launched it on 17th November 2020, when we were really very, very bothered by COVID, but still we did take the opportunity. And now that COVID is receding, I would say, I hope we get more people involved in this project. Now, what has WHO told us? We have spent 50 years in setting up all this, right? In setting up pap smear and setting up screening, manpower training of doctors and paramedicals. We have got centers in all the states, but FOXI is trying to cover all the states and all the districts, and we have standardized our protocols. All this is done. But what we need to do more is involve the nurses and paramedical staff and BSc trained technicians. We have to upgrade all laboratories for liquid-based cytology, HPV testing. All this is still a lot of work to be done. And all medical personnel to be made aware, and gynecologists are going to be the leaders in this patient care. That is your role, a very important role, but you need the support of all these people. Now, this is my slide on co-testing. Why do you have to do so many tests? Even patients ask that, the GPs ask that, the doctors ask, because each test gives different information. Cytology gives morphological changes, LBC is better, immunocytochemistry gives us whether HPV infected cells are there, colposcopy gives the size of the lesion. How can you remove something without knowing what is it, the size? You have to plan the size of the loop. You have to plan whether she needs admission or OPD. Everything depends on this finding. And the HPV test is very important molecular test. It is totally objective. And I'm telling you, you have to select the choice of the kit depending on what you're looking for. Of course, nowadays it can be done self-sampling. Patients can bring their own sample into the lab. But you must tell the person who is doing self-sampling that you have it your way, you do your own sample, but remember you are not getting the benefits of an examination of genital tract. We don't know from where this is coming and what is the lesion, we don't know, and still we are giving reports and planning treatment. So I feel we have to be little careful about this. Now I come to this very important question of the long-term predictors of failure of treatment of CIN. Why follow-up is required? I think our student was asked, how will you follow up? And she had no answer to give because poor thing, she has never been told also why are we doing follow-up? Because there may be failure and you may have the lesion developing. So important thing is pathology. Again, I'm happy that Nikhil brought up this issue that pathology is so important for us. If the margins are involved in your LEAP specimen, it's very important to know. If there are clear margins are not involved, you have gone beyond the level of the lesion, only 1 or 2 people in 100 will get a recurrence, very negligible. If there is endocervical extension, as I showed you in one of the slides little earlier, it has already gone to the endocervix, then about 10 out of 100 will come back with a recurrence in the endocervix. If the margin status is unknown and not done or not recorded, this is happening. Unfortunately, we are getting many reports where pathologist says, I cannot judge, I cannot the specimen is not enough, whatever it is, there are cases with unknown margin status. Then it is 20%, 20 out of 100 will come back with a recurrence. We don't know how. Now, post-treatment HPV test is a very sensitive predictor. Post-treatment, the HPV test must come negative. That is what we are saying. And if you do frequent cytology testing for 2 years, you will pick up the recurrence also quite easily. So just tell the patient, warn her from the beginning, 2 years you have to come here for your follow-up because there is a risk always. After all, you are dealing with something which is viral. We don't know the prediction. Take care. Okay, Partha Basu of IARC has suggested annual Kaijin test or HPV test for 3 consecutive years. It can be taken up to 5 to 6 years also. It's a very sensitive predictor. And as I told you, the importance of basement membrane is very important. It's not an anatomical barrier only. It's an immunological barrier. And it is the zone of post-tumor interaction. And we need this infection, the status of the basement membrane very much to know what is happening. And remember, HPV is a multicentric disease and it is present in the entire genital tract. It is not going to go away so easily. And I want to tell you something about this researcher person called John Durbar. He gave some sensational news to us when he came for the IFC conference, and he said that metaplasia with HPV, it will neutralize the P53 and the retinoblastoma gene. They are our tumor suppressor genes. They suppress the formation of any tumor. And imagine they are neutralized by the HPV when it occurs with metaplasia. So what defense do you have? Tumors will form. So an endocervical glands serve as a reservoir of HPV. And in oropharyngeal cancers, the tonsillar crypts serve as reservoirs. So there is something like latent HPV which lies in the body for a long time. So it's a very worrying situation. And we have biomarkers E6 and E7, which tell us about P53 and retinoblastoma gene. So, you know, these tests are all just about coming into the market and are becoming reliable, and we need to use them. That is the difficult situation. So first of all, let me give you some issues of hope. Don't think we are at the end of our hope and we can't solve our problems and we are going to need more and more help to solve this. No, not like that. There are some projects which are going on, which are going to reduce the incidence of cervical cancer. One is age at marriage at 18 years is itself very, very helpful because the epithelium becomes little more mature after 18 and can take carcinogens and inflammation and all that. Then educated girls is said to be the most important factor. The percentage of educated girls is related to the incidence of cervical cancer in a given population. And in India, school education for girls is free. Nowadays, they give a lot of incentive to girls to not be dropouts. And there are social agencies, Rotary clubs, women's groups, they give bicycles to the girls so that at least they can go to school long distance also. Then these girls are getting some inheritance from father, so they are not totally at a loss not to be able to go to a doctor for if she has symptoms and things like that. Then very good cancer policies are available to all the low-income families also. And now we have small families and good obstetric care, thanks to all you practicing doctors looking after these things, and that will itself help to bring down. So, alleviation of poverty, better housing and water supply, and creating health awareness, which is what all of us are working on. All these are the United Nations Sustainable Development Goals 1 to 5. And that brings me to the question of reducing mortality due to cancer. So we have to think in terms of guidance for good health, treat genital infections adequately, as I told you, get health workers to communicate in local languages, then identify a literate, young, bright family member for liaison. Like this girl has to now go to school and learn online, so the whole family is learning how to do online. You can understand that this girl in future is going to now look after the other members of the family. And you encourage screening and vaccination of the whole family. Now we can use modern technology, mobile phones everybody has, SMS is available, WhatsApp is available. And I do believe that you please involve male members of the family. Don't keep this cervical cancer screening and vaccination all only for women to know about and women to be involved. No, it's not good enough. And this is a very nice poster made by one of my doctors who said the father should take the girl to school and enroll her. And the father should take her on her 12th birthday for HPV vaccination. And the husband should take his wife for screening. So we want family involvement, you can say. Everyone should be involved in this project. And now I come to this issue of reducing mortality. And I know Yogesh will talk about the cancer cervix and advanced cases, and I don't want to infringe on his subject, but I want to tell you about this, that United Nations says that 30% reduction in all cancers has to be achieved by 2030. So that gives us 8 more years. And no one has really made any protocol for this. And I've been thinking, because I set up a cancer ward in Kama, and I know patients are coming from Yavatmal and wherever they come, but there is so much delay. There's no system. We have to set up a system of how to refer cases. And even late cases can be saved with current treatments. We have seen our patients go home after good treatment. Palliative care is every patient's right. Don't deny it. Pain relief and right to die with dignity should be given to every patient, whoever she is, and we must all believe in it. Morphine tablets are prescribed by cancer institutes, but the method is so difficult, nobody can reach there and get it in time, and it's not of use. We must improve that system. And hospice care, we have a good hospice in Mumbai, and we have some good ones in Goa, and there are some good hospices, but we need more maybe. Now, referral is what I'm talking about. We refer cases to cancer hospital. They are treated well there. They will get the treatment. But the time factor, let the decision be made to refer and how to refer, and let the patient reach properly with all data. That is not happening. Patients are coming to Kama with one little chit block saying refer to Kama hospital. They don't know where to go, who to go to, what is the previous treatment, nothing. So we should send with a nurse or an ASHA worker, some relative, all documents, biopsies if it is done in an ambulance, and send a phone call, SMS, emails to be working. It's not working half the time, and take an appointment so that they're not disappointed. And I must announce here that I think all of you must be knowing that WHO in last month gave an award to ASHA workers for the excellent community service. 1 million strong ASHA workers we have who are giving excellent service. And I've seen ASHA workers sometimes bring the patients to our hospital, and they are so good, so sympathetic. Then one thing I want to tell you is this is the sort of ambulance I showed when I gave a talk in Northeast. We covered the whole 7 Northeast states with Foxy Oncology Committee last year. And they said, Madam, your ambulance is not at all suitable for our country, for our states. There are hills up and down, and their solution is a bike ambulance. So they sent me the picture of bike ambulance. I hope you can see. And people do solve their own problems in their own way. I said, this is perfect. I'm going to show others. We can also have this where roads are not adequate. So that is the end of my talk, and I hope I have given you in my last few slides rays of hope. I'm sure and very hopeful that all of you will do a very good job of this. And the other ray of hope is that the therapeutic vaccine is available now. Therapeutic vaccine was not there. We only have the prophylactic vaccine, but it has been reported at the ESME conference. And in fact, we had a recent meeting in Mumbai. Some of our Foxy doctors were there, and they want to know whether we should launch it in India. So there are a lot of new things coming up. So my last slide to say that prevention we started with, early detection is important, public education is important, HPV testing we need to use more and more. We must promote HPV vaccination for primary prevention. And I know we are increasing the role of gynecologists. Gynecologists and obstetricians are already so busy. They don't have that much time. But with the help of our supporting staff, the ASHA workers, the nurses, the technicians, I'm sure all of you will reach the goal of elimination by 2030. And my best wishes to all of you for taking an interest in this subject. It has not been talked of as much as some of the other subjects, but I hope you will take it up and make it a success. Thank you, Dr. Motwani, and thank you, AFG, for this wonderful opportunity to give this talk. Thank you.
Madam, thank you so very much. AFG thanks you with all his heart. Thank you so very much for being with us today, giving us so much information about the subject. No subject on cervical cancer is complete without you, because you have really, you put in years and years.
I have got at least 50 people who are very well trained to give this talk. Let me assure you, I also feel very happy that there are so many people who can give this talk now, and it is required, and you can call on them. There's a list available, and they can do very good talks they are giving, my students. I'm very happy for them.
A good teacher always creates good students, ma'am. And you've been with us for a long, long time. We admire the passion you still have for this subject. And believe me, because I move around with my colleague gynecologists, the enthusiasm about screening is not still so high among the OB/GYN specialists. Honest talk. We have really been taken with the backside. Okay, chalta hai, kiya, nahi kiya, screening kiya, chalo. We have never really seen in discussions. This should ignite a lot of minds to go in full-fledged and do our bit for the patients, because it is the gynecologist who comes first when it comes to screening. The gyno-onco people come later.
No,
anyway,
gynecology people are too busy reducing mortality and treating patients.
In fact, we should reduce their radical work.
No one likes to go to cancer hospital when they don't have cancer. So let us rely only on gynecologists, general practitioners, and social workers.
Madam, since you have been so much into cytology, your few words regarding the ideal screening techniques, let's say in rural areas and in Mumbai, because we have still a talk on, we did discuss about VIA. What is the role which only HPV alone without cytology or with cytology? What would you recommend?
No, VIA, to me, VIA is very important.
Yeah,
anyone
so that's what even Nikhil was of the idea.
Yes. Anyone who looks at the cervix, whether it is the nurse or a GP or a gynecologist, is going to find out a lot of information. So VIA is a basic test we must promote. Now, I don't believe in treating a patient with VIA alone. You know, that I don't quite agree with, because it is a very non-specific test. It is positive today, 6 months later, it is not. It's epithelium is changing. But use it definitely to diagnose, and let the nurses do. I'm training the nurses in Kama for this. And they learn how to put the speculum, they learn how to use it, and out of 100, 10 become VIA positive. So your workload is reduced from 100 pap smears to 10 pap smears.
So is there any role of co-testing today, madam, in private practice, HPV plus cytology?
Yeah. I myself don't rely on one test. So I can't tell you that one test is enough, because I want confirmation. My patients want confirmation, and I can't plan treatment on VIA alone or on pap smear alone, not knowing where the lesion is. No, we are all academicians. We want to give the best treatment to our patients. And my patients will come if I tell them that, look, I'll make a diagnosis after 1 month when I get all these tests. I mean, they do listen. I know we are not dealing with village people, so I can't say what is to be done in the villages or primary health centers, but as far as possible, make a diagnosis. I think so. I hope you all agree. Don't treat without knowing.
At what age would you start screening in our country? 30, 35?
30 to 35 is enough. Yeah. No, don't start too early. And HPV test is not allowed only below 30.
That's true. That's true.
No meaning.
And up to 65?
Yes. And those who want to continue, we don't stop them. There are many people I have who are past 70 also and who are still coming regularly. I don't deny anyone a test checkup. There are other cancers, there are other issues. We have to look after them, no?
Madam, there are two questions for you. One says, is it wise to subject pregnant patients to pap smear or VIA? And the second is that somebody wants to know the name of the therapeutic vaccine.
No, it's not marketed yet. It's still in the realm of research, the therapeutic vaccine. It's not marketed, but one of the companies in India wants to import and do some trials. So it will come. No, the second question you have said about pregnancy. Pregnancy is not a good time to do screening at all. We don't want to start bleeding. We don't want to put speculum. But if a person says, I've never had any screening, then don't miss that opportunity. And you do it after the 3 months are complete, 4th, 5th, and 6th months you can do. And pap smear will not cause any harm at all. You can do, and sometimes it's very good. We diagnose infection, and then that treatment will help her not have preterm labor. And polyps we diagnose so many things. And colposcopy, if you have to do, it's not harmful. It is not at all harmful. You can do it safely. But if the pap smear is normal, I always say we'll do it after delivery. But don't miss the opportunity. That's the main thing.
Karthik, there was one more question, I think. The last one we just came. What is it about?
I just saw. Somebody says that I would like to know how to we investigate, counsel, and if necessary, treat the male partner.
Yes, counseling the couple is important, I think, because they have some interpersonal problems that come up, and I don't like that at all. And the male partners, we are sending to the urologist to check, because there are sometimes some warts diagnosed, and we do go into their history also and find out what is the what could have led to this HPV infection. And the second thing is that very soon the HPV vaccine will be given to boys and girls. So then really the control will come. In the meantime, we are not advising vaccination to the male.
Madam, thank you so very much for those great words, for such lovely carry-on messages. Thank you so very much. I know you're busy. You got another talk around 12. I think we've just given you some time to sign off. Thank you so very much.
Thanks
Grateful for the part of
all
AAG.
the best
Thank
to
you.
all of you. And I'm sorry I missed Nikhil's talk. Some other time I'll catch up. Thank you,
Madam,
Nikhil.
we'll be on YouTube. The entire program will be on YouTube in the next few days.
Then
We'll
I
send the
can,
link. We
I
will
can
send the
do
link
that.
to you. We'll send the link to you.
Sure. And
Thank
all
you,
to all the participants, thank you for listening. Yeah.
Thank you, ma'am. Thank you. Anyway, friends, we go back to the next part on our program. We have another case discussion. Now we have Dr. Aarti Sanaf. Has she joined?
Yes, sir.
Aarti, you've joined. Just let Madam sign off. Aarti, are you there?
Yes, sir.
Yeah, please. So I think we should start. We have all the examiners waiting. Dr. Nikhil, Dr. Yogesh. Yeah, Aarti, please start. Thank you.
Aarti, you can start your presentation and then share the screen.
Sir, I'm unable to share the screen.
No problem. Take your time. In the meantime, we'll keep the conversation going. Dr. Nikhil is right there. You can always add. Nikhil, before she goes on, can you give us a little bit about HPV vaccination?
Well, I think most of you are doing HPV vaccination. I think what we need to know is that Cervarix has stopped. I don't know whether it's available in Mumbai because here in Pune we don't have. Let us start. We'll talk. We'll
please. Okay, great. Aarti, fine. Go for it.
Sorry. Sir, myself, Dr. Aarti Sanap, from the Nauroji Wadia Maternity Hospital. I am presenting a case on the carcinoma of cervix. My patient is 60-year-old old woman, married since 40 years, para 3 living 3, resident of Prabhadevi, belongs to lower middle socioeconomic status, which she complained of postmenopausal bleeding and the vaginal discharge since 6 months. She was apparently alright 6 months back, following which she complained of postmenopausal bleeding, which was irregular and lasts for 1 or 2 days with spotting per vagina. She also complaining of white discharge per vagina, which was foul smelling, blood stain, and not associated with aging. She also gave the history of fatigue and tiredness. There was no history of urinary urgency, increased frequency, or the dysuria. No history of any bowel complaints. No history of something coming out per vagina. No history of weight loss or the loss of appetite. Menstrual history. She was postmenopausal since 7 years. Menarche attained at 13 years of age. The previous cycles were regular, 28 to 30 day cycle, moderate to painless. She did the tubal ligation, and there is no history of use of hormonal contraception. Past history, no history of diabetes, hypertension, asthma, or any major surgical or the medical illness. Personal history, she ate a mixed diet. There is no history of any addiction. Family history of not significant. On examination, general condition was fair, febrile. She was moderately built and adequately nourished. Her BMI is 22 kg per meter square. Her weight is 54 kg and height was 156 centimeter, and the mild pallor was present. There was no edema, icterus, clubbing, or the lymphadenopathy. BP was normal, which was 110 by 70 millimeter of mercury. Pulse was 92 beats per minute. Respiratory and the CVS systems are normal. On per abdominal examination, per abdomen was soft, no guarding tenderness or rigidity was there. Tubal ligation scar was present. No sinuses or the dilated veins are there. No organomegaly or the palpable inguinal lymph nodes. On per speculum examination, there was an exophytic growth seen arising from the entire cervix of size 3 by 3 centimeter with areas of ulceration. The upper part of vagina looks indurated. On the per vaginal examination, a palpable hard indurated mass involving the entire cervix was present, which is fixed and bleeds on touch. Uterus is bulky, bilateral formations are firm and tender. Parametrium is indurated and fixed. Upper two-thirds of vaginal wall is indurated. On per rectal examination, bilateral parametrium is indurated and hard, and the rectal mucosa is free and mobile. My provisional diagnosis is a 6-year-old woman with married since 40 years, para 3 living 3, with postmenopausal bleeding and the post-vaginal discharge with exophytic cervical growth, likely to get stage 2A cervical carcinoma as per the FIGO clinical staging 2018.
Hello, Aarti.
Yes, sir.
Yeah, is your history over or anything is remaining?
Sir, my history is over.
Over. Okay. Now there are a couple of things. I noticed in your history. One is obviously you haven't had a mention of breast examination in your general examination, right? Now, any female patient, when you examine, we have to examine breast, or at least you have to mention that you have examined the breasts. Okay, number one. Number two is, how do you stage cervical cancer? How do you come to a conclusion that it's cervical cancer only and nothing else?
So there are DDs, but the growth looks like the cervical cancer.
Looks like, but it is not proven.
Not
right?
yet.
Yeah, so you can't put it as a diagnosis. Now, if I have to ask, what could be the differential diagnosis?
That can be cervical ulcer or the polyp or the normal erosion of the cervix.
Anything else? Have you seen cervical tuberculosis anytime?
No, sir.
Cervical tuberculosis presents exactly like CA cervix. Okay, they have a growth which is exophytic, it bleeds on touch, and it is almost obviously, it's not something which is very common, but carcinoma or cancer as a diagnosis has to be mentioned only when you have biopsy proven thing. Till that time, you should not mention that, because there have been couple of cases, if I may mention, so where a patient has been mentioned in their history as cancer and it turned out to be non-cancer and they sued the doctor for causing the emotional trauma. Okay.
Just to complete the list, Yogesh, there is another thing which we mimic it very closely is chronic inversion of uterus.
Correct. So that is another. And the third thing that I will highlight in your history is, if you go back to, can you go back to your slide of examination? The PVPR examination. Yeah. So you have written that upper two-thirds of vagina wall is indurated, bilateral parametrium is
Indurated.
Fixed, right?
And hard.
So what does that mean?
Parametrium involvement is another stage.
Is it, do you mean, is it involved or not involved?
Involved.
It is involved. Then if it is involved, then go back to your next slide.
It can't be stage 2.
How can it be stage 2A then?
It will be stage 3.
No. So I think if I have to advise you, in your provisional diagnosis, you should mention it appears like a cervical cancer, but you have to do a biopsy to prove that it is correct. Okay. So now next is, what are you going to do about this patient? How are you going to evaluate?
Sir, I would like to do first the clinical examination, in which I would like to do the cervical biopsy, punch biopsy in the OPD. And after cervical punch biopsy, histopath report is suggestive of the cervical cancer. I would like to treat the patient with chemoradiation.
Let us go in a stepwise manner. So you have done the examination. Now you want to go ahead with the biopsy, right? Will you do the biopsy in outpatient department, or would you like to do an examination under anesthesia with biopsy?
So first I will do the biopsy in OPD, since patient.
In outpatient department you want to do. Now I give you a scenario. You have done an outpatient biopsy and patient start bleeding profusely. What will you do?
So we prefer it under examination at examination.
No. I mean outpatient. No. You are absolutely right when you say that you can do an outpatient biopsy. But you are going to land in an exam. They will ask you, okay, you did a biopsy and the patient starts bleeding profusely, which is very likely, right? When there is an exophytic growth, the patient will bleed. Then what will you do? I am giving you a situation and I want, as a doctor or as a gynec, what will you do?
Even a PV can start a bleeding, just a per vaginal examination. What is the commonest way you manage bleeding? At least for the time, sorry?
The vaginal packing and admit the patient and start around.
That's the only thing that you can do in your OPD, right? So you keep a pack ready, soak it in betadine and pack the vagina. And most of the time that should stop the bleeding, right? Okay. So now you have done the biopsy. Okay. Do you have the biopsy report for this patient? Do we have the report or we don't have it?
No, sir.
Okay. So I give you a report that it's a squamous carcinoma of the cervix. Okay. So now how will you go further?
Squamous cell carcinoma, and I will like to treat the patient according to the stage and the lymph node involvement. With this scenario, the treatment plan of treatment is chemoradiation.
No. You see, every cancer, irrespective of the cancer you are treating, has 4 aspects of the treatment and evaluation. So first thing is you see the patient in OPD. 2, you establish the diagnosis. 3, you analyze the extent of spread of the disease. And 4, you plan the treatment, right? You have to go in this manner. Any cancer patient, okay, irrespective of any part of body the cancer is, these are the 4 basic steps in evaluation and planning the management for the patient. So you have skipped, and most important part is how will you evaluate this patient?
I would like the blood investigation, CBC and LFT-RFT, followed by the biopsy report. And if the biopsy suggests of carcinoma, I would like to do the MRI. For the MRI for involvement of parametrium and the extent of the disease.
Okay, let's go to your imaging techniques. Which is better, MRI versus CT versus PET?
CT is best for to check for the extent metastasis of the cancer. MRI for the parametrial and cervix parametrial involvement, and PET CT mainly for the involvement of lymph node.
Aarti, can you just tell us what is stage 3 of CA cervix?
Stage 3 is involvement of lower to third. Stage 3 is divided into the 3 categories. Stage 3A is involvement of lower 1/3 of the vagina. Stage 3B is parametrial involvement up to the lateral pelvic wall and the hydronephrosis or the non-functional. And stage 3C is divided into the C1, that is involvement of the pelvic lymph node, and stage 3C2 is involvement of the para-aortic lymph node.
What imaging will you do to get these? That is what sir is asking.
PET CT.
What will you do? You said PET CT.
For the lymph node involvement.
Okay. So can you tell me what is PET CT? Basically, you have an idea. What?
So PET CT is dye is detected and the FDG uptake of the tumor cells is increased.
So why? Sorry. So what is the difference between a PET CT scan and a CT scan?
The dye injected in the CT PET.
So you also give contrast in CT scan. So the basic difference is PET CT is a biological imaging. It combines the biological processes that are happening in the body along with imaging. And CT scan is only it will tell you that there are enlarged lymph nodes. But whether those lymph nodes are actually involved because of the disease, the PET CT will be able to tell you. Okay. So now if I have to choose, okay, you have 3 imaging available. Give me in one word answer, which one will you do? MRI, abdomen and pelvis with contrast, CT scan, abdomen and pelvis with contrast, or a whole body PET CT scan for this patient, not in general.
CT scan, CT with contrast.
CT scan, abdomen and pelvis with contrast. Okay. I think, you know, in practicality, it is because PET CT may not be available at every place. And when you are wanting to do a metastatic workup, CT scan is a good imaging modality to evaluate. Okay, but if you have a PET CT scan available, probably you should prefer a PET CT scan over a conventional CT scan. But a CT scan is a good answer. So if I have if I have to give you, you know, you have to divide the imaging stage wise. For early stage cervical cancer, probably MRI is the best imaging modality. For locally advanced cervical cancer, that is stage 2 onwards, a CT scan or a PET CT scan would be a better imaging modality. Okay. So you have done the, we have done the PET CT scan for this patient. Okay. And the PET CT shows, a large growth in the cervix, which is showing the uptake. There are pelvic lymph nodes and there are para-aortic lymph nodes. So then what will you do?
The treatment plans will be the chemoradiation with the cisplatin 40 milligram per meter square, followed by the radiotherapy. Radiotherapy in the form of external beam radiotherapy started first, and after the tumor leaves the particular site, then the brachytherapy started.
Yes, continue. Yeah.
Brachytherapy can be given in the form of low pulse dose rate, or the pulse dose rate, or the high pulse dose rate.
Okay. And radiation, I just gave you a scenario where there are enlarged lymph nodes. Would you like to confirm that these lymph nodes are involved by disease, or you would just consider that they are positive?
I would like to do the USG guided biopsy, FNAC of the lymph nodes. First the pelvic lymph nodes, then.
Yes, so I think if the PET CT shows enlarged lymph nodes, okay, it may not always be necessary because of the disease, okay, because PET CT can also show in case of infection. So suppose somebody has a large cervical growth, there is a high possibility that the growth can get infected and the lymph nodes may be actually infective rather than metastatic in nature. So it's always better to have a confirmation by doing an FNAC or a biopsy from the lymph node. Now, if the para-aortic lymph nodes are involved, you need especially to do the biopsy or FNAC from the para-aortic nodes, because that will change the entire course of management. Okay, either you may have to extend your radiation field, or you may have to consider the patient for giving chemotherapy upfront. Nikhil, you want to add something?
Yeah, only thing is, most of the times what happens is taking biopsies from the para-aortic lymph nodes. Okay, most of the interventional radiologists are not so keen, or trained. So there might be a situation, and I have had 2 such situations where we had to do a para-aortic lymph node sample. Luckily, both of them turned out to be positive, and the patient was subjected to chemotherapy first. But yes, pelvic lymph nodes can be sampled, and you can prove that. We do it very commonly. But only problem is that if the para-aortic lymph nodes are shown to have a high FDG uptake on a PET CT, not many of the radiation and medical oncologists are friendly enough to give their radiation or chemo upfront. Many a time they would ask for a biopsy, because many of times even para-aortic lymph nodes are found to be infective. So in very selected cases, sometimes we have to do a para-aortic sampling. I've done it in 2 or 3 cases. That's it.
Which should be
know what is good. The involvement of the parametrium has a good prognosis, or involvement of the nodes have a good prognosis, which is, of course, both are bad, but amongst them, which is good. So what do you think? A 2B, 3B is more better than a 3C?
Involvement of parametrium will be more better.
Why?
It can be surgery can be done if the parametrial involvement is there. But if the lymph node involvement, it will be more complicated surgery if the lymph nodes are involved, and the radiation.
So you are trying to tell that because you can do surgery, that is why prognosis is good or bad?
The metastasis is more in the lymph, if the lymph nodes are involved.
I don't know. I'll have a word with Dr. Yogesh sir. What is happening is in most of our private centers, we are getting patients where you have CA cervix directly going straight. The idea is it has to go lateral to the parametrium and from there go up. Here we are getting scenarios where you have a CA cervix and direct a pelvic and a para-aortic lymph node metastasis, and imaging is showing everything negative in the parametrium and down in the vagina. So when we have seen these patients where the metastasis is going like this rather than like this and like this, we have found that nodal involvement in absence of parametrium and a vaginal involvement, they do very well. Post CTRT, the OS is very good as compared to patients where there is parametrium, even if it is 2B or 3B, because most of the parametrium involvement do also have along with it microscopic spread in the nodes. I wanted to know your experience.
No, I think the lymph nodal involvement and the parametrial spread are absolutely two different things, because parametrial spread is basically a local spread of the disease laterally, and lymph node involvement is essentially a sort of thing that is dependent on lymph vascular space invasion. Now, theoretically and prognostically, disease, once it's a para-aortic node positive, that is basically a metastatic disease. Okay, and in all practical purposes, they should fare worse than patients who have only parametrial involvement technically. And that's why, parametrial infiltration is a lower stage as compared to a lymph node involvement, because the overall prognosis of that subgroup is inferior.
But sometimes I found something different over here, where nodes are there, but local spread is not there. So
you see quite common in endometrial cancer, where there are lymph node positivity, but the tumor is not deeply infiltrating into the myometrium, because lymph node metastasis has to do with the lymph vascular space invasion more, okay, rather than a local spread into the parametrium. That's what my explanation would be.
Yogesh, you mentioned that the lymph nodes have to be sampled before we start the treatment, because you want to know the stage of the disease, to stage the disease. So would you prefer an FNAC, or would you want a surgical excision?
I think FNAC. If you have to do surgery, you have to abandon it, to be very honest, because I think anything, if you have to give radiation after a surgery, the morbidity is very high. And especially for para-aortic lymph nodes, unless you are doing it laparoscopically, if you are doing an open surgery to do a para-aortic sampling, because even the FIGO does not specify that you have to do an FNAC. Okay, they say radiological imaging is also equally or acceptable but the only thing is that you have to mention whether the lymph nodes were positive based on radiology or whether the lymph nodes were positive based on FNAC. So I don't think it is absolutely must. So if the para-aortic lymph nodes are not accessible, or the radiologist is not comfortable doing it, rather than doing a surgery, we assume that they are positive and plan the treatment accordingly.
Perfect. You also mentioned that you need to examine the breast.
Yeah.
In a case of cancer cervix. Why?
No, it is not because we didn't know that it's a case of cancer cervix. For all female patients, say she might have a case of ovarian cancer or ovarian mass. Okay. And there is a possibility that it could be a metastatic from a breast mass to the ovary. Okay, so I think a breast examination should be part of any gynecological examination, be it benign gynecology or malignancy.
Okay.
Dr. Aarti, I just wanted to ask you a question since you have presented this case. Next time in your OPD, you have a case with an exophytic growth on the cervix. What will you do for your next patient? Here you said you have taken you have done a biopsy, and that is where your question was, what happens if there is bleeding, and believe me, this really bleeds torrentially. I had one of my resident doctor doing a biopsy, and we had to give hemostatic RT to control that bleeding. So I just wanted to know, next time you go in the OPD, you have a same 3 by 4 centimeter exophytic cervical growth. Would you learn something from this case, or you will again go to the OPD and take a biopsy?
No, sir. I will counsel the patient, admit her, and do the examination under general anesthesia and biopsy.
what other information will you get when you do a EUA? Besides the biopsy and besides, having a biopsy under controlled atmosphere. What do you do at EUA? I just wanted to know, what is EUA in a CA cervix?
The parametrial involvement and
Okay. Okay, so EUA will help you in staging. You can do a PR, patient is relaxed. It will know you have written indurated parametrium. You will actually feel whether it is involved. Induration is not the word, it is involved or uninvolved is the word. Second, what you can also, you have written about vaginal disease. When you're doing an EUA, what I generally do is I also take Lugol's iodine and stain the vagina. So if you have a iodine uptake negative, you can also understand the depth of vaginal involvement, whether it is upper third, 2/3. You can take biopsies, you can do a proper clinical staging, and you can avoid a torrential bleeding. So if you have exophytic growths, please try and avoid doing biopsies because you will land up in a situation for which you were questioned by Kulkarni sir.
yes.
Okay. So, can you tell me, in brief, okay, so you do, what is the chances of success of treatment in this patient if you give them chemoradiation?
Chances of in stage 2B 58%, 55 to 58%.
The 5-year survival for stage 3B is?
Stage 3B is 30%.
It's about 45%. Okay. Anything else that you know? Is there any other treatment option that you would like to explore? Are there any other options of treatment apart from chemoradiation in this patient?
Radical, apart from chemoradiation is the primary modality of treatment, and if the tumor shrinks to the this can be done radical hysterectomy.
Radical hysterectomy for her? No.
No, sir, but no preferred modality.
Yeah. And suppose you have given radiation, okay, so you completed the radiation. 3 months after that, there is still growth in the cervix. Okay, so obviously she was one of the non-responders for radiation, which happens in about 20 to 25% of patients. What would you do? So this patient has come back to you after completing radiation in your OPD at the end of 3 months, and there is still some disease there that you can see.
For the local recurrence, sir, I need the symptomatic rather than the surgery or the pelvic exenteration surgery can be done.
Pelvic, what you said?
Exenteration.
Hear you, huh?
Exenteration.
Exenteration. Why would you do exenteration?
Is the bladder involved or rectum?
In recurrence.
What is the difference between? See, I'm. Please don't get me wrong, but these are something fundamental concept that you need to know. What is the difference between residual disease and recurrent disease?
Residual disease is the disease is present even after the treatment and not.
Correct. But till what time? When will you call it a recurrence and when will you call it a residual disease?
How many months? How many months? Or how many days? Or how many years? What is that line between relapse and recurrence?
I don't know exactly, sir, but 3 months.
I can't hear you.
Sir, I
She
don't
said,
know, but 3 months.
So 3 months for recurrence.
I don't know, sir.
So residual is anything within 6 months. If there is a disease there, it is residual. Okay. Okay, about that, anything that comes, say after a year, it fall in the group of recurrence. So what he's asking you is at 3 months, if there is some lesion there, so that means it is part of a residual tumor. That means it is not being completely treated, is what he wanted to know.
Correct. So
what will you do?
Residual disease. Now, your approach to, and why you need to know that is because your approach to treatment, if it's a residual disease versus a recurrent disease, is totally different. Okay, if it's a residual disease, that means, okay, I have decided that I want to treat this patient by chemoradiation, but it has not worked. But I have to find other way to treat the remaining disease. That's where comes the role of surgery. Okay, where you can think of, okay, now there is a small tumor there in the cervix, so let us go ahead, do the surgery and remove the tumor. Okay, recurrent disease is, in spite of your treatment being successful, the disease has come back within a year. That means there are two things that you have to read into it. One, maybe the treatment that was given was not standard, or two, the disease is very aggressive, that in spite of your best efforts, the disease is coming back. So your approach to treatment becomes totally different in these two scenarios. Okay, so if it's a residual disease, you as a surgeon become as aggressive as you can be, because these patients can be cured of the disease. If it's a recurrent disease, within a short span of time, the disease biology is very aggressive. So in spite of your aggressive efforts, the patient may not sustain, because you may do the surgery, within 6 months, the disease may come somewhere else. So that's why you need to have the line between what is a residual disease and what is a recurrent disease, right?
That's why gives you a hope of treating that patient. That is more important. So if you have a central residual disease, say less than 2 centimeters after your chemotherapy, the patient comes with say 1.5 centimeter central lesion, you can definitely offer surgery and you can cure this patient. So you can make them cancer free. And when it comes in recurrence, and recurrence doesn't come singularly, it is there somewhere, hidden somewhere else in the body. So you'll have to investigate where is the recurrence and what could be you'll have to go through the entire histopathology of the previous record. You have to go through you'll have to add additional IHCs, where things faltered and why did she come with recurrence. So there's a lot of difference in managing residual and recurrence. Okay.
Aarti, in which cases of CS cervix and what stages of CSF would you advocate a radical hysterectomy? Type 1, type 2, type 3? Have you read about it, or should we proceed? Because Yogesh will be covering it.
Sir,
which stages? Now, suppose that stage is stage 1B.
Stage 1B, up to the stage 1B2, sir, modified radical hysterectomy will be done. And 1B2, radical hysterectomy, and stage 1A1, simple extrafacial hysterectomy. Stage 1 up to the 1B1, modified radical hysterectomy.
With pelvic lymphadenectomy?
Yes.
What is modified radical hysterectomy? Is it with, when you say modified radical hysterectomy, is it with pelvic lymph node or without pelvic lymph node?
Sir, without pelvic lymph node.
So what about 1B2, 1B3? What is 1B, 1B2, B3, by the way?
Stage 1B, tumor size, 1B1 is tumor size less than 2 centimeters. Stage 1B2 is tumor size less than 4 centimeters. And stage 1B3 is tumor size more than 4 centimeters.
Okay, I think Dr. Yogesh will be covering this, but just 1 or 2 points on what actually you mean by radical surgery. Just 1 or 2 points. I mean,
radical surgery is removal of the uterus along with the cervix, and mobilization of the ureters, and ligation of uterine artery from its division from the internal iliac artery. Mobilization of the bladder up to middle 1/3 of the vaginal wall, and removal of upper 1/4 to 1/3 of the vagina, and mobilization of the rectum up to middle 1/3 of the vagina.
Most important is removal of the parametrium. The most important part of these surgeries is removal of complete parametrium. That only makes your surgery complete. And then, of course, vagina and of course, those things will be covered by sir. So I'm not going more into it.
No, let's wrap up the case.
Yeah, let's wrap up, I think. So thank you, Aarti. Aarti, thank you.
Yeah, thank you, Aarti. You done quite well. Okay, no worries.
Sure.
But you need to be very specific about your findings and how to describe them. See, inspection and palpation are two different things. And you need to think clinically when you examine a case. So when you present a case, so that the examiner should realize that you reach a diagnosis on history, investigations, and then you go to the treatment. You've done that.
Thank you.
There are a couple of questions now on vaccines, HPV and vaccines. One is now which HPV test should be offered? DNA, RNA, PCR. And the second one is about. And the second one is which says which vaccine should be better, the nanovalent or the quadrivalent vaccine in terms of cost.
So I think
third question would be what would be
concerned, sir. There are two types of tests as far as my understanding goes. Okay, it's either a hybrid capture 2 assay, which is the most commercially used test, and HPV DNA PCR. Now, the difference between hybrid capture assay versus HPV DNA PCR, apart from the only difference that I see is in hybrid capture, they just mention whether the patient is positive for high risk HPV DNA or not. While in HPV PCR, they mention the specific type of high risk HPV DNA that the patient is positive for. I think, but the cost wise and the time wise, hybrid capture 2 assay is the test which is most commonly used. Okay, most of the commercial labs are using HC2 tests basically. So from that point of view, that is one. Second thing is about the vaccine. Now, technically, theoretically, the nanovalent vaccine has to be more effective than a bivalent vaccine because it is covering 9 types of HPV. When we are talking of bivalent vaccine, HPV 16 and 18 constitute about 70% cases of cervical cancer in India. Okay, so rest 30% are still because of some other types. Okay, so if it is possible, affordable, I think a nanovalent vaccine technically should be a better choice of vaccine than a bivalent vaccine. I don't know whether Gardasil 9 is still available in India. Is it available?
Yes, G9 is available, nanovalent vaccine, and besides what they also say is it is available. And second, it is also for prevention of anal oral cancers also besides cervical, plus vulval and vaginal. So there are the therapeutic applications have broadened with the use of G9 because of the addition of 5 other strains of vaccine, and it is freely available. It is available.
Yeah. Okay. So that is the answer, sir.
Motwani sir, can the students stop the screen sharing so that we can?
Yeah, I think she will.
Motwani sir.
Can I share my screen now?
1 minute. She has to stop sharing screen. Aarti, can you stop sharing a screen, please? Aarti. Yep, she's stopping it. Anyway, friends, now for the last part of our program for the day, we have Dr. Yogesh Kulkarni with us. A very small CV. He just gives 2 lines, as Dr. Nikhil also gave me 2 lines. He is a practicing gynec oncologist and a robotic surgeon, and he's been practicing for many years, trained at Tata Memorial Hospital for many years, and he's at present at the Kokila Bay in Dhirubhai Ambani Hospital, which we call KDAH. He's going to speak to us about management of cervical cancers. Yogesh, it is all yours.
Yeah, I'm sharing my screens. Just a moment, sir. Can you see my screen, sir? No?
Yep.
So thank you, Bhagat sir and Motwani sir, for giving me this opportunity. It's always great, to have an association with AFG. So I won't be boring everybody too much on a Sunday afternoon. I think we are all set. So I'll try to wrap it up about investigations and management in a case of invasive cancer. Now, this presentation I have kept in mind, in terms of that most of the students, would have a fairly good idea about how to go about evaluating a patient, what is the standard surgical procedure, what is the role of laparoscopy, which is quite controversial, and what is, a treatment of locally advanced cervical cancer. Now, we all know that the incidence of cervical cancer in India is dropping. Okay, we are second to breast cancer, especially in overall number of cancer cases, but the mortality rate because of cervical cancer has not dropped down. And the reason for it being majority of the cases are diagnosed at an advanced stage. So as a gynecologist, practicing gynecologist, our endeavor has to be to offer screening services, and as far as possible, try to diagnose the women at an earlier stage where they have a better chance of survival. So what symptoms that we need to look at? Any kind of abnormal vaginal bleeding in a premenopausal or a postmenopausal. In a premenopausal, especially any kind of postcoital bleeding should not be ignored, because I think that can be one of the first warning signs of cervical cancer or an abnormal cytology. Patients with abnormal vaginal discharge, pain and limb swelling happens in very late course of the disease. So that's not very commonly the presenting symptom, and the same is true about bladder and bowel symptoms. So majority of the times, the women would come to OPD either with an abnormal vaginal bleeding or an abnormal vaginal discharge. Now, how do we go? The first part is examination, and I think it's the most important part. So we have a general evaluation of the patient, look for edema, look for nodes, the supraclavicular as well as the inguinal nodes, and look for pallor, because pallor can be a surrogate marker for a woman who has been bleeding for over a period of time, and that can give you an idea about what could be the severity of bleeding. Once we are done with that, you go into the local examination and evaluate the vulva and the vagina, because HPV can be a phenomenon. It can affect the entire bout of squamous epithelium, starting from the cervix up to the vulva. So what we call as a field change in the squamous epithelium. So it's absolutely vital to have a look at the vulva and the vagina before you start your internal examination. After you examine the external genitalia, you do a per speculum examination and try to evaluate the cervix. Now, again, here you have to be very, very gentle and careful, because you push your speculum directly into the growth and the patient can start bleeding very torrentially. So I think being gentle, use a little bit of jelly, insert the speculum into the vagina as gently as possible, and then evaluate the cervix. On per speculum examination, you have to look at the cervix for any kind of growth or ulcer, and if that growth or ulcer is bleeding on touch, then you move your vision all around the cervix into the fornix to see whether the fornixes are good, and then you have a look at the anterior and posterior vaginal wall. Once you have done with per speculum examination, then you do a per vaginal or per rectal or a bimanual examination, where you try to, again, you have a very gentle, if possible, do a single finger PV, especially because if there is a large growth, again, there can be a bleeding from there. So with that, you have a look at or judge the size of the growth, and then you move your finger all around the cervix to see whether any part of the fornix is involved. Then you also assess the mobility of the uterus, and then lastly, with a bimanual examination and a per rectal examination, you try to assess whether the the parametrium and the uterosacrals are involved or not. Now, if the patient is uncooperative, if the patient is obese, if the patient is unmarried, and where you are not able to do a satisfactory examination, do not hesitate to do an examination under anesthesia, because that would really help you give an adequate information about the whole thing. Now, once you are done with examination and you have come with a provisional diagnosis that the patient may have a cervical cancer, then the pre-treatment evaluation starts. So first history, then examination, and then pre-treatment evaluation. First and foremost, an absolute must is established tissue diagnosis. A lot of times we see patients come with an abnormal pap smear and you want to start treatment based on that. It can never be done that. No cancer treatment can be started unless you have a biopsy proven cancer. Even though the cytology is suggestive of cervical cancer, it is still not a diagnostic test. You have to confirm the diagnosis by doing a tissue biopsy. staging of the disease. Now, initially it was always clinical and examination under anesthesia. In case if the clinical examination is not fine, then you want to do a systemic evaluation, by doing an imaging, whether the lymph nodes are fine, whether the liver and kidneys are fine. Cystoscopy and sigmoidoscopy you very rarely require, even though it has been mentioned as a part of the FIGO protocol, it should be done only if required. So if you feel that the growth is along the anterior vaginal wall and is infiltrating the bladder, you do a cystoscopy. Or if the growth is deeply infiltrating the posterior vaginal wall, you do a rectocolonoscopy or a sigmoidoscopy to evaluate. And then you do all the regular evaluation. So if I have to break down the evaluation in 3 parts, one is the examination and the biopsy. Second part is evaluation of the patient's health in general by doing all the blood tests that you do. And third thing is metastatic workup or systemic evaluation, where I would like to know what is the status of the disease in terms of whether it is confined to cervix, whether it has gone to the parametrium, or whether it has gone to the lymph node. Now, imaging, I think we had a discussion. There are 3 imagings that are available to you. You have a CT scan, you have an MRI, and you have a PET scan. Now, there can be, everybody will have different opinions about what is the best modality of imaging to be used. But in my practice and in general, if it's an early cervical cancer, use an MRI, because the parametrial infiltration, the size of the tumor, the depth of infiltration can be best judged by an MRI. As far as lymph node goes, probably CT scan has more accuracy and a PET scan has the most accuracy in terms of evaluating the lymph node. So why we need to understand the, the imaging is because the cervical cancer staging has undergone major changes in 2018. So, the tumor 1B, which was 1B1 and 1B2, now has been divided into 1B1, 1B2, and 1B3, depending on the size of the tumor. And the next thing is lymph node involvement, which was never a part of the FIGO staging before, has been now involved as a part of the staging. So we have to make all precautions possible to evaluate the lymph nodes and, sort of certify that the lymph nodes are either involved or not. Because, it has become mandatory, because if I have to compare a stage 3A, across the world, now, unless the lymph nodes are involved, because there are 40% chance that the lymph nodes will be involved in a particular stage. And if you have not evaluated the lymph nodes, it is very difficult to compare the outcomes between different groups. So it is absolutely vital to evaluate the lymph nodes. Either you do it by radiological imaging, and if the radiological imaging is suspicious, you can do an FNAC or a biopsy from the lymph node. So whatever modality that you have used to evaluate the lymph node has to be mentioned. So if you see there is an RNP rotation. So if the lymph nodes are positive based on radiology, you have to notify it as R. If it is positive on pathology, you have to notify it as P. So that is a new change that has developed in the staging of cervical cancer. So how to implement clinical examination is still an important part. When the resources are limited, imaging evaluation to be added for local spread, and nodal status or distant mates. Modalities can be USG, CT scan, MRI, or PET scan. Tumor more than 10 millimeters, MRI is the best evaluation in terms of assessing the spread. If the nodal mets, PET CT is the best with a false negative rate of only 4 to 14%. But the unfortunate part is PET CT also has a false positive rate. Use FNAC and biopsy from nodes to confirm. And para-aortic nodal assessment either can be done by imaging. If imaging is suspicious, do a biopsy. If that is not possible, in very rare circumstances, if the radiation oncologist insists, then you may have to do a open biopsy or a laparoscopic para-aortic lymph node biopsy. The rule of thumb, whenever you are in doubt, assign lower staging. So suppose I am not sure that clinically the patient is 3B and the lymph node status is not very clear, you don't assign the patient to 3C1 or 3C2, you assign them to 3B. Imaging and pathology should be incorporated in staging whenever is possible. Indicate whether imaging or pathology used to assign staging, and whenever you send a biopsy, ask the pathologist to mention about lymph vascular space invasion, because that has to be mentioned as a part of the cervical cancer staging 2018. Then coming to the biopsy, there are different types of histology of cervical cancer. The most common being squamous, followed by adenocarcinoma, the small cell, verrucous, and other carcinomas or carcinosarcomas of the cervix are extremely rare. So most of the discussion, about the treatment will be restricted to squamous carcinomas and adenocarcinoma. Now, cervical cancer can be divided into two stages, or early stage cervical cancer, which can be divided into micro-invasive or superficially invasive cancer, and an early invasive cervical cancer, which could be 1B1, 1B2 as per the new classification, and 2A1. And then locally advanced cervical cancer, anything beyond 2A2 to stage 4A is a locally advanced cervical cancer, and a metastatic cervical cancer will be stage 4B. We have to divide cervical cancer into these stages or these groups, because the treatment approach to each group would be slightly different. Early invasive cervical cancer, they are potentially curable with surgery. It's a wide group starting from stage 1A to stage 1B2 and 2A1, and it is a group with an excellent survival. So when you are talking about superficially invasive cancer, 1A1 and 1A2, where the depth of infiltration is either less than 3 millimeters or depth of infiltration is 3 to 5 millimeters. Superficially invasive cancer, basically these people or these women do not have a growth on their cervix. They are clinically asymptomatic. The cancer has been diagnosed during an evaluation of an abnormal smear. They have undergone an excisional biopsy, either a leap or a cone. Okay, I think, leap has its own problems because there can be, cautery artifacts along with leap. So if fertility is not a concern, a cone biopsy is preferred when invasive disease is suspected. And the management of these women will be based on depth of invasion, whether the lymphovascular space invasion is present or not, what is the desire for fertility, fitness for surgery, and histology. Now, when we are talking about stromal invasion, is it really important? And this graph will tell you, if the infiltration is less than 3 millimeters, the risk of recurrence is 2%. If the infiltration is 3 to 5 millimeters, the risk of recurrence is almost double, 4%. That's why the depth of infiltration has to be mentioned on a cone biopsy specimen. The same thing applies to lymphovascular space invasion. Why do we have to mention LVSI in our histopath? So if you see, even in a stage 1A1, where the depth of infiltration is less than 3 millimeters, if the lymphovascular space invasion is positive, the risk of recurrence is 5%. And the same thing, if the depth of infiltration is 3 to 5 millimeters, and if the lymphovascular invasion is positive, the risk of recurrence is 17.45% versus 4% if it is negative. So all your treatment decisions will be based on these two factors when you are dealing with a micro-invasive cervical cancer. What is the depth of infiltration and what is the lymphovascular space invasion? So this is roughly a chart. I think, it's a bit a busy slide, but I'll try to simplify it for you. So 1A1 is when the depth of infiltration is less than 3 millimeters. So when you have done margins negative and positive, is because you would have done an excisional procedure on this patient. So if the margins are negative and the fertility is not desired, you can go ahead with a simple extrafacial hysterectomy. And if the margins are negative and fertility is desired, you just leave it at that. But if the margins are positive or the lymphovascular space invasion is positive, you need to go ahead with a type 2 radical hysterectomy and the pelvic lymph node dissection, because the risk of lymph node metastasis in these women is quite high. The same thing applies to stage 1A2. So the standard treatment with 1A2 is type 2 radical hysterectomy with pelvic lymph node dissection. But if the patient desires fertility, then in rare circumstances, you can consider a radical trachelectomy with bilateral pelvic node dissection, or a cone biopsy or a radical cone with bilateral pelvic lymph node dissection. Now, it is too complicated. So let me simplify it for you. So if it's a superficially or less than 3 millimeters, if the patient does not desire fertility, go ahead with the hysterectomy. If the patient desires fertility, go ahead with the cone biopsy. Except when the cone biopsy margins are positive or lymphovascular space invasion is positive, do a type 2 radical hysterectomy. And for all stages 1A2, do a type 2 radical hysterectomy unless the patient strongly wants preservation of fertility. So I think I am quite sort of simplified this. Coming to the next stage, management of 1B and 2A1 cervical cancer. Here there are two options. Either you go ahead with surgery or you can go ahead with radical RT. They both are equally good results and they both provide same amount of loco-regional control and survival. So there is nothing to choose even in early stage cervical cancer between surgery and a radical radiation therapy. But when we decide, you take these factors into consideration when you are planning for treatment. What is the age of the patient? What are the medical comorbidities? Is she fit for surgery? What is the need for ovarian conservation? What does the imaging suggest? If the lymph nodes are enlarged or not? What is the patient's desire? Does the patient want surgery or does the patient want radiation therapy? And last but not the least is available expertise. When we are talking about cervical cancer, we are not talking about Mumbai. We are talking about interiors of India and Maharashtra, where all the facilities may not be available at one place. So at one place, say a radiation facility is available. So, it's worthwhile going ahead with radiation for that patient rather than sending the patient 300 kilometers away to do a surgery where there may be a further delay into the treatment. So when you are taking a decision, whether you want to go ahead with surgery or radiation therapy, please take a decision as a whole, not only based on what you feel is correct. So consider the patient factor, the medical factors, and the patient desires into your decision making, and then you discuss it with patient and then take a final call. Now, when we are talking about radical hysterectomy, it is about radical resection of the parametrium. So you can see here in this video, this is the parametrium, and that is a component of radical hysterectomy apart from removing the vaginal cuff. And also you also have to remove the pelvic lymph nodes or complete the entire bunch of pelvic lymph nodes. Now, how the surgery for cervical cancer evolved. So Clark in 1895 was the first one who did radical hysterectomy. Wardhams in 1898 sort of standardized this procedure with a radical hysterectomy, and it also included removal of the bulky nodes. Shota was the one who first did a radical vaginal hysterectomy in 1901. Okabayashi, the Japanese surgeon, evolved the concept of nerve-sparing radical hysterectomy to avoid the complications after radical hysterectomy. What we understand today is what we do is mixed modification of Wardhams, which is basically a type 3 radical hysterectomy with a systematic lymph node dissection. We have an Indian contribution where Dr. Mitra suggested, apart from doing a radical vaginal hysterectomy, you can combine it with extraperitoneal lymphadenectomy so that the patient does not have a morbidity of opening the peritoneum. Dargent, the French surgeon, British surgeon, first did the radical trachelectomy, the fertility preserving surgery for cervical cancer. The first laparoscopic radical hysterectomy was done in 1989, and the first robotic radical hysterectomy was done in 2006. So in a nutshell, this is how the surgery for cervical cancer has evolved for over last 120, 130 years. This is the type of radical hysterectomies that we understand, the Piver-Ruetelas classification. There are 5 types. Type 1 is the regular hysterectomy that we do in all cases, so that is a type 1 extrafacial hysterectomy. Type 2 is a modified radical hysterectomy where you remove do not remove the parametrium completely up to the pelvic wall, but you only remove the parametrium medial to the uterine vessels. Okay, so you remove the medial half of the parametrium. The type 3 radical hysterectomy is the radical hysterectomy where you remove the parametrium up to the pelvic wall, ligate the uterine vessels at its origin, and remove the pelvic lymph nodes completely. Type 4 is basically, apart from ligating the uterine artery, you also ligate the superior vesical artery and remove the upper 2/3 of vagina. In type 3, you remove the upper 1/3 of vagina. And type 5 is basically extended radical hysterectomy with bowel, bladder, or ureteric dissection. Now, for all practical purposes, 4 and 5 are not used. Type 1 is the one which we regularly use. Type 2 is the hysterectomy that you do in superficially invasive cervical cancer, that is 1A1 and 1A2. And type 3 hysterectomy is what you do in stage 1B cervical cancer. So that's how you would remember it. Now, you have to understand that a hysterectomy approach for a benign disease versus when you are doing it for a cancer is totally different. in benign disease, when you are doing it for fibroid or for say endometriosis, you are basically going intraperitoneal. While in malignancy, most of the things you do retroperitoneally. So your understanding of retroperitoneal anatomy becomes an absolute must. What is there in the retroperitoneum? You have vessels, you have nerves, you have the spaces, the pararectal, paravesical, and the prerectal space, and you have the viscera, which you have to dissect from these tissues, the ureters, the bladder, and the rectum, because part of the bladder is also, most of the bladder is extraperitoneal. So if I have to tell you about the steps, how do I go about a radical hysterectomy? So you open the abdomen. The first thing is you evaluate the paraortic area and the upper abdomen. See that there are no metastases there. The next step would be to go ahead and do a pelvic lymph node dissection. So we do the pelvic lymphadenectomy first, so that in case if there are any bulky nodes, you can send them for frozen. The third step is development of the pelvic spaces, the paravesical and the pararectal space. Fourth step is ligation of the uterine vessels. Fifth step is the most crucial step of a radical hysterectomy, which decides the quality of your surgery, is the ureteric dissection. You have to dissect the ureter completely from the parametrium. Then you can go ahead with the parametrial resection. Then you can go ahead with the vaginal cuff excision. So to do an adequate parametrial resection and to do an adequate vaginal cuff resection, an adequate ureteric dissection is a must. So if I have to pinpoint one step which is absolutely crucial and which can decide the quality of your surgery, it would be a ureteric dissection during a radical hysterectomy. Now, pelvic lymphadenectomy, it is the single most important prognostic factor. So you have stage 1B1, lymph node positive versus lymph node negative. There is a significant drop in the survival if the woman is found to have lymph node positive. And you need to target all these areas. So this is the common iliac area. This is the external iliac, obturator, internal iliac, and the presacral node. So these are the 5 lymph node basins that you need to resect. So I have here put down all the margins, okay, for lymph node dissection. So this is your proximal margin. This is the ureter. This is the common iliac artery. So where the ureter crosses the common iliac artery, that's the proximal margin. The distal margin is where the circumflex iliac vein crosses the external iliac artery. That's your distal margin. The medial margin is the internal iliac artery and the internal iliac vein. Sorry. The lateral margin is the genitofemoral nerve, and the inferior margin is the pelvic side wall. So you have to decide these margins, and then whatever tissue is there, you have to resect it completely in order to do a complete pelvic lymph node dissection. The next thing is understanding the spaces. So this is a paravesical space. Paravesical space is basically the space which bladder occupies when it's full. So it's a space which is lateral to bladder, lateral to the obliterated umbilical artery, and medial to the external iliac vessel. And the pararectal space is the space which lies between the rectum and the ureter. So again, it is divided into medial and lateral pararectal spaces. I won't discuss that, but and the tissue that lies in between these two is the parametrium. So here is the pararectal space, here is the paravesical space, and this is the parametrium, here where you have to resect the parametrium. This is the uterine artery, which is ligated, or which has to be ligated at its origin. This is a complete ureteric dissection. You can see the ureter here going, and here you can see the ureter completely dissected of the peritoneum going into the bladder wall. And this ureter was somewhere here. You have to dissect it laterally so that you can resect the entire bunch of the parametrium. So if I have to put radical hysterectomy in one word, it is a procedure all about lateralization of the ureter. You have to take the ureter completely away from the parametrium laterally so that you can resect the parametrium completely. And once you have done that, this is where your cut margins are. This is where you cut the McIndore's ligament close to the pelvic wall. This is where you cut the uterosacral ligament close to the sacrum. So that completes your parametrial resection. And this is the vaginal cup. Almost about 2 to 3 centimeters of vagina has to be removed, which is completely disease-free. So this, in a nutshell, would complete about all your, a radical hysterectomy. Now, if I have to tell you I have to name one surgery one pelvic surgery which teaches you the entire pelvic anatomy. It is a Vardhan cystectomy, because in Vardhan cystectomy, you have to dissect the arteries and nerves, you have to dissect the vessels, you have to dissect the ureter, you have to dissect the bladder and rectum, and you have to dissect all these organs and then remove the uterus without injuring any one of them. So if you understand Vardhans and you learn Vardhan, I think any pelvic surgery becomes a cakewalk, for you. So how this surgery has evolved? Obviously, we were doing a radical surgery, but as science has evolved, it is not about how much you remove. It is about how much you can save. So there were the concept of radical trachelectomy, which Dargent introduced in young women desirous of fertility. You don't need to remove the entire uterus. You can only remove the cervix, and that they can continue with their fertility. This was done for fertility preservation. And there is certain amount of morbidity that is associated with radical hysterectomy. To reduce that, there came the minimal access surgery, the laparoscopy or a robotic surgery. Then there came the nerve sparing approach, which was basically introduced by Okabayashi in 1921. And then there came the role of sentinel node mapping. Why to do a complete lymph node? Why not to just do a sentinel lymph node that has been done in breast cancer or vulval cancer or some of the other cancers? So this is how it evolved. So there has been a new classification has been developed in radical hysterectomies, because the old classification was very objective, so very subjective. I feel I have removed the parametrium, which may not be true. So they tried to make the classification more objective. Then there came the nerve sparing radical hysterectomy, laparoscopic and robotic radical hysterectomy, trachelectomies, and sentinel node biopsy. So this is the new classification, which is called as Querlo and Monro's classification. And here the type A equivalent to type 1, similar. Type B equivalent to type 2, similar to what was the old classification. Type C, which is divided into C1 and C2. C1 is the nerve sparing approach. Initially, there was no nerve sparing approach classification in radical hysterectomy. Type C2 is the type 3 radical hysterectomy, what we knew as a conventional radical hysterectomy. And type D is a combination of type 4 and 5 of the old classification. Again, most of the cases, either we will do a type B, type C1, or a type C2 lymphadenectomy. And here they have sort of objectively divided and decided what should be the ventral margin, what should be the dorsal margin, and what should be the posterior margin and anterior margin of your resection. So here you can understand, if in C1, you are not resecting, this is the uterus, this is the bladder. You are not resecting the entire, vesico-uterine ligament, but you are resecting the lower part of the vesicle, the upper part where the nerves are there, you are trying to preserve. So this is somehow, this is the newer classification which has been introduced, which is most widely used nowadays. The second thing is about sentinel node mapping. Should we do an extended lymphadenectomy, because there are a lot of problems that are associated with lymph node dissection. That includes, limb edema, post-operative lymphoria, long-term lymphangitis. So there was an evaluation, can we give a dye into the cervix? But as of today, it is still not the standard practice, because the sensitivity is not as high as was expected. It's almost 78%. And the detection rate are 89%. So as of today, we still are doing a conventional lymphadenectomy, except maybe in very early cervical cancers. By and large, sentinel node biopsy is a technique which is getting evolved, which is getting scrutinized. Conservative surgery or radical trachelectomy, yes, it is a definite option. But to be very honest, in my 20 to 25 years of gynec oncology practice, I have seen only 3 or 4 patients where we had to do a trachelectomy. But there are criteria. The woman has to be desirous of fertility. The tumor diameter has to be less than 2 centimeters. It has to be squamous carcinoma, limited endocervical involvement, and you have to do an MRI and be absolutely sure that there are no regional lymph node metastasis. And this is the principle of a radical trachelectomy, where you just cut the cervix with the upper part of the vagina, and then you anastomose the uterus with the vagina. So that's a simple principle. They have their own problems, in terms of higher rate of recurrences, or the recurrence rates are acceptable, but higher rates of preterm deaths. And worldwide now there have been more than 1,000 radical trachelectomies have been done, and there are more than 800 pregnancies reported in these women. we did one patient, you know, who was 4 years old for a clear cell carcinoma of the cervix. We did this radical trachelectomy almost in 2010. So here you can see the cervix with the specimen and the parametrium. And this was the reconstructed uterus. But, you know, as I said, radical trachelectomy, you will get once, maybe 4 or 5 cases in your entire course of 40 or 50 years where patients are suitable for radical trachelectomy. Now, the most controversial topic of the day, you know, the role of minimal access surgery for cervical cancer. And I think for all these years, we believe that, you know, the laparoscopy or a robotic surgery is absolutely safe for cervical cancer. There is absolutely, because it gives patient less pain, less hospitalization, and all the other things. But this was squashed by a trial which was done, which is widely known as a LAC trial, that is laparoscopic approach to cervical cancer, which was actually presented in SGO 2018 or 19, and then which was published in NEJM in 2020. And this was the first randomized trial which compared the outcomes of minimal invasive surgery versus open surgery. You know, up till now, it was individual. I have done 100 cases and I don't find any recurrences, so it's safe. But medicine does not work like that. You know, if you want to prove two methods, it has to be compared with the standard method to prove that it is equally effective, if not better than the ones which we are using right now. So that was the idea behind this trial. And what they found, that the disease-free survival at the end of 4.5 years was 10% less with minimal access surgery as compared to conventional open surgery. So that was the first, you know, point in favor of open surgery. In terms of overall survival, at 3 years, open surgery, almost 99% of the patients were alive, as compared to minimal access surgery or laparoscopic surgery, only 93%. So there was a 6% difference in overall survival. In terms of disease-specific survival, there was a 4% difference. So I think, so there is a difference in overall survival, recurrence-free survival, disease-specific survival. Recurrence rate, you can see the 4 times more recurrence rates with minimal invasive surgery as compared to open surgery. So this was a trial, and they compared in terms of complication, you know, the complication, the rates were more or less similar. But yes, there was a slightly higher post-operative morbidity, non-significant though, with open surgery as compared to laparoscopic surgery. So, and they also compared the quality of life, because that is something that everybody was talking, you know, that the quality of life of patients with after laparoscopic surgery is better as compared to open surgery. So they also analyzed the quality of life, including different scores. And what they found, that almost all quality of life was similar in both groups at 1 week post-operatively and thereafter. So up to 1 week, there was a slight difference, but after 1 week, they were exactly the same. The mobility was the only factor of difference at the end of 1 week. So you have laparoscopic patients who had slightly more mobility and much comfortable as compared to open surgery, but this also lasted for only 6 weeks. So in terms of overall survival, disease-specific survival, recurrence rate, laparoscopy is inferior. In terms of quality of life, at the end of 1 week, both are the same. So I think that's what I wanted to highlight. Then in the same journal, there was another article which was sort of a SEER data group analysis. Okay, again, they found that before 2006, okay, the survival of, you know, the survival curve was very nice for cervical cancer. But after 2006, when the introduction of robotic and more minimal access surgeries were done, the survival was steadily declining, you know, for cervical cancer. And the risk of death at 4 years was 9% with minimal access as compared to 5% with open surgery. So why there was so much of controversy? I think, you know, everybody there, you know, the world is divided currently on this, because I think nobody expected these results. I think everybody thought that as we have seen with all other malignancies, laparoscopic will be equivalent to open surgery and there will not be no problem. But even the investigators themselves were surprised by seeing the outcome that they have seen after these trials. The other thing is, I used to do robotic radical hysterectomies, and I may not see the recurrences in my practice, but modern medicine is not about what I do or an individual does. Modern medicine is about what are the results in community in general. Not every surgeon will be of the same skill levels as some of the highly trained laparoscopic surgeons. And if they do a radical hysterectomy, are the outcomes the same? That's the question. The reason for failure, people say, why would it be so? It has not been seen with endometrial cancer. It has not been seen with rectal cancer. Why would it be so? And that was not the purpose of this trial. I mean, the trial was there to prove whether laparoscopy is good enough or not. Why it is not good, the investigators would not know. And lastly, I interact with a lot of laparoscopic and robotic surgeons who have been honing their skills to develop, because everybody wants to do a laparoscopic radical hysterectomy, because that's a surgery, as I said, it's a more complete pelvic surgery. You feel immense satisfaction if you have done it open. You will get even more satisfaction if you are able to do it laparoscopically. But so it's very difficult to give up something. It's like today, I learned all my life learning right-hand driving, and suddenly I had to give up that and drive from the left side. I'm going to get flustered. So it is something. It's very difficult to give up something which you have mastered over a period of time. So what this trial actually did, and it did to me, and it did to all the laparoscopic surgeons across the country, anybody who was willing to think and accept, okay, there is some sense in what they are talking, it made me ask the right question and look at my data. Okay, I mean, I felt that there were no recurrences, but is it really so? So it made the surgeons ask the right questions, and across the world, people have done multiple trials and multiple retrospective analysis across and in different parts of the world. You can see there is one in Canada, one in Korea, one in United States. Some of them found, a very high difference in their morbidity. Some of them did not find. But currently, even the European Society of Gynecologic Oncology recommend that approach for radical surgery is no longer valid. Minimal invasive approach is no longer valid and should be removed and replaced by open surgery, because that's the gold standard. So that's what most of even the GOG, even the SGO are not advocating minimal access surgery. And it's not that robotic is better. Robotic has also been found to be equally less effective in treating cervical cancer. So worldwide, there has been a complete blanket reduction in the number of laparoscopic radical hysterectomies that have been done nowadays. Now, what is our perspective? When I look at it from Indian perspective, we even are in a worse situation because our training is not standardized. And with all due respect, everybody who learns laparoscopy feels they have the right to do a radical surgery. So I see a lot of laparoscopic surgeons who haven't had an exposure to open surgery have been trying laparoscopic surgery. So the training is not standardized. Again, the quality of laparoscopic surgery, you don't have a procedure where somebody has to certify that you are good enough to go ahead with a laparoscopic radical surgery. So we don't have that validation. So that becomes a problem. Again, the larger tumor size. Now you see this study was done in United States where most of the patients had tumors less than 2 centimeters in size. In India, to see a patient with a tumor less than 2 centimeter size is rarity rather than a norm. So again, we are dealing with larger tumor size where the outcome is likely to be even more inferior. And the duration of hospitalization, which is a concern in Western world, is no longer a concern with us, to be honest. Our patients, even though after they do a robotic surgery, they want to stay in the hospital for 3 days. After open surgery, they may stay for 5 days. So the duration of hospitalization is not as much a concern for Indian population as it is to the Western world. So I had this debate in one of the gynec oncology, and I asked them the question, how do I counsel my patient? Okay, you have 4 times more risk of recurrence. You have 6 times more risk of dying of cervical cancer. The complication rates are same. There is no difference in short-term or long-term morbidity. You may walk slightly with the difficulty at the end of 1 week, but beyond 1 week, there is no difference in quality of life. But I still believe you should undergo a laparoscopic radical hysterectomy. And trust me, we have stopped doing robotic radical hysterectomies after the data came. And every time a patient comes, I show this slide. And I am yet to see one patient who has come and told me, no, I still want to go ahead with laparoscopic hysterectomy. So that's what is evidence-based medicine is all about. We cannot criticize evidence. You either create evidence or you follow evidence. You can't just sit back and say, in my practice, it is not there. I don't think because most of the patients nowadays have access to data, access to internet. They will go on the internet. If they have a recurrence 3 years down the line, they are going to come and ask you, doc, you had the laparoscopy was shown to be inferior. You didn't tell me, why did you do a laparoscopic radical hysterectomy? And you will have no answer for that. So till the time we get a better answer to it, it's better to stop, and it's time to move on from laparoscopic surgery or a robotic surgery for cervical cancer to open surgeries. Now, coming back to the complications of surgery, I'm sorry, I think, sir, am I shooting?
Go on. No, please go on.
Yeah. So the complications, basically, you can have intraoperative complications, the vascular injury, ureteric injuries, nerve injuries, and they have to be managed on table depending on what happened. These are the problems that you can have. Bladder dysfunction is quite common after radical hysterectomy, because you are dissecting the nerve and denervating the bladder. The risk of ureteric fistula is 0.5 to 1%. There can be lymphocyls, lymphorias or lymphedemas, infection, and DVT and embolism. So this was one of my case, who had a ureteric fistula post-operatively. You can see there is a clear-cut leak of urine from here. And what we did, the first step would be to go ahead and do a stent. If that is not possible, then you will have to do Then the next thing you will have, once you have done the hysterectomy, the management of cervical cancer is very, very mathematical. So these are the 7 or 8 parameters that I want you to look in the histopath report. What is the size of tumor? What is the depth of infiltration? Lymphovascular space invasion, vaginal cut margins, parametrial cut margins, lymph node involvement, what is the cell type, and what is the grade of the tumor. And based on that, you just divide. Patients who have parametrium positive, lymph node positive, or vaginal cut margin positive, they go for concurrent chemoradiation after surgery. Patients who have deep infiltration, lymphovascular space invasion positive, or tumor size more than 4 centimeter, if 2 of the 3 criteria are present, they go for only adjuvant radiation. So again, it's pretty mathematical. You don't need to think about it. It's very clear, to decide which patient require. And anybody who does not have this does not require any further treatment after surgery. There are advantages of surgery, in terms of equivalent result. You can retain the ovarian function, the vaginal function is retained. You can have a better understanding of the histopathology report so that you can plan the adjuvant treatment and the risk of recurrence. And lastly, it gives patients immense psychological benefit, and that cannot be denied, that okay, the tumor is out of my body, and that gives them that relief. Okay, so there are certain advantages of surgery, but in spite of being a surgeon, I always advise everybody that whenever you are planning a patient treatment for cervical cancer, you have to be honest with yourself. Is the patient, as a surgeon, I have to ask myself, is the patient going to require radiation after surgery? If the answer is yes, don't operate. Okay, because surgery followed by radiation has maximum morbidity. So I think you have to choose patient in such a way that they can be treated with either surgery or radiation rather than combination of both. So that's where the role of radiation comes, for locally advanced cervical cancer, especially from stage 2A to 2B, a radical RT, that is external RT plus brachytherapy plus concurrent chemotherapy is the standard of care. Concurrent chemotherapy with cisplatin, which is a low dose chemotherapy, and that acts as a radiation booster. It improvises or improves the function of radiation. And concurrent chemoradiation, rather than giving only radiation, is the standard of care, because there is a significant advantage of adding that small dose of cisplatin along with radiation in treatment of locally advanced cervical cancer. Again, intracavitary brachytherapy, external cavity brachytherapy sort of takes care of the entire pelvis. Intracavitary brachytherapy gives radiation to the area, that is cervix, which is affected the most. So you have better control of the local disease when you add intracavitary brachytherapy, to external radiation. And nowadays there are newer modalities, the intensity modulated radiation therapy. So it sort of improves the tissue sparing, reduces the dose to the bladder and rectum, and it improves the tumor control probability. There are again complicated, but when you are talking about complications of radiation and surgery, there are 2 different sets of complications. The surgical complications are likely to be in immediate post-operative period. while radiation complications are likely to be late. Okay, so there is loss of ovarian function because the ovaries get fired. Unless you transpose them outside the pelvis, there is loss of sexual function. There can be bowel complications, small bowel obstruction, and late complications, which can be quite debilitating, the radiation proctitis and cystitis, and in very rare situation, a radiation-induced fistula. So the complication profile is totally different for surgery and radiation. And when you combine what the point that highlighted, that you have to choose patient very carefully, because you add this surgery with early complication, and on top of it, you add radiation with late complication, you can imagine what's going to be the quality of life of patients after that treatment. So that's why there is a strong understanding that you do surgery only when you are, in spite of all your careful selection criteria, 15% of patients may still require radiation after surgery. But at least in 85% of patients, you should select patients in such a way that they do not require radiation after surgery. Neoadjuvant chemotherapy, I think it's something that has a rationale that you give chemotherapy, reduce the size of the disease, and then give radiation, but it's not the standard practice. So I won't be discussing this too much. So to conclude my talk, I would say superficially invasive cancers are optimally treated with surgery, unless the patient is desirous of fertility. For 1A1, extrafacial hysterectomy; for 1A2, a type 2 radical hysterectomy with pelvic lymph node dissection based on what the LVSI. Please ask for depth of infiltration and lymph vascular space invasion when you are looking at the biopsy report. For early stage cervical cancer, surgery and radiation treatment are good, but the treatment must be tailored to give patient the best chance of survival with least complication and preservation of normal functional status. Radical trachelectomy is a surgery which you can do in a select group of patients. Laparoscopic surgery, as of today, in my view, should not be offered to patients of cervical cancer unless they insist for laparoscopic surgery after understanding the risk that is associated with it. Locally advanced cervical cancer, radical radiation plus concurrent chemotherapy is the standard of care. Neoadjuvant chemotherapy needs evaluation. With this, I conclude my talk. I thank you all for a patient hearing me. I hope I haven't bored you too much with my talk. Thanks a lot.
You haven't bored us. You have really kept us going. Such beautiful talk covering every aspect of CS cervix, right from diagnosis to management, and such clear-cut concepts of management. Thank you so much, Yogesh. There are two questions for you, I think. There is one question which says, do you routinely send frozen section analysis of pelvic lymph node dissection specimen? And if positive, abundant radical hysterectomy?
Yes, yes.
And the second is, what should be the approach in centers where we don't have frozen section facility?
No, I think then you go ahead with the surgery. I don't think, see, if you feel, obviously we have done a clinical evaluation and radiological evaluation of the node. And if you feel the nodes are radiologically negative, you don't need to, you can go ahead with the surgery. If it is not available, we can't deny the patient surgery on assumption or because of lack of availability of frozen.
There's another question is imprint cytology good enough in absence of frozen?
To be honest, I have no experience with that, sir. I have never used that. So I really don't know how accurate it is. But I think if you don't have a frozen section, it doesn't mean that it's not a must to have a frozen section. I think a lot of centers across the world do not do routinely lymph nodes for frozen section.
There's a question from one of our members. She says she's a stage 3 cancer cervix. She has received chemo plus radiation. Now, after 4 years, she's got a recurrence. How does she go about it?
It depends on where the recurrence is, sir. Okay, because you have to classify recurrence as local recurrence and distant recurrence. Okay, if it's a local recurrence and there is no metastasis anywhere else, she can be a candidate for surgery. But if there is a distant recurrence, then we have no choice but to consider her for chemotherapy plus or minus bevacizumab, which is the current standard of care.
In fact, PET-CT would be the best way to evaluate this. And probably that will help us guide her whether it is local, distal, and what. So probably this is the best candidate for a PET-CT. And secondly, I wanted to also stress on what Kulkarni said, sir said, ki there is the role of monotherapy in early cancers. So either we do a surgery or we do radiation. It has to be very clear that early cervical cancer is basically treated only by monotherapy, and we should have very less instances where we have to do a surgery also and later on give a radiation also. In few cases, fair enough, but in majority of the cases, so nowadays the need for doing a radical surgery is keep on. So if you have a radiation oncologist in the group, he'll say, well, I'll be better off than you treating even a 1B1. So you now it is not fair to accept somebody having a series of surgeries as far as CA cervix is concerned, because it is monotherapy.
Anyway, before we sign up, there was a question regarding a little elaboration on the vaccine, regarding the age, the number of doses, and the interval between doses. Has there been any change in this? Like suppose we use the Gardasil vaccine. It is 1, 2, and 6, usual one. Suppose do we have a young girl who's less than 15? Still
less than 13 years, sir, you only need 2 dosages.
Okay.
The duration between the 2 dosages should be less than 6 months.
And if she misses, if she goes beyond 6 months, then
you can do a catch-up vaccination up to 12 months, but then she has to take 3 dosages. If she misses the dose,
so she re-goes to the entire cycle again.
Yes. And after that, after 13 or I think 13 or 15, I'll just confirm.
It is 9 to 15, 9 to 15,
yeah.
And 16 to 28, 3 doses.
3 doses.
There was another question before we sign up. Dr. Sangeeta seems to have a good set of questions. Medico-legally, early stage case, can gynec operate?
Yes, if you can do it, you can operate. I mean, we as a gynecologist are trained in cancer surgery. We are supposed to be trained in cancer. So if you are trained, you can operate.
Anyway, wonderful friend. This can go on and on. What a lovely morning it has been. Thank you so much, Yogesh, Nikhil, and Dr. Usha is not around. Dr. Usha Saray is not with us. Such lovely messages, take-home messages. He's been a delight for me, and I'm sure it's been a delight for the delegates too. Thank you very much, ladies and gentlemen. On behalf of AFG, we thank Yogesh, Nikhil, and Dr. Usha Saraya for making it so special. A Sunday, you spend some time with us. I hope you are happy. We've stolen a lot of your hours of your family life. Thank you so very much.
I just admire you. Every time I see the RAN Symposia, you and Dr. Bhagat are always there. I can understand how you manage to do this. How your minds are not complaining, basically.
That's because of friends like you.
See,
that's because of friends like you.
See, we realize it's time to give back to the students. So that is the reason we take help from experts like you. And you have like-minded friends like you. Always a pleasure. Yes, Karthik.
The only complaint is it was not live.
I think we'll get over it too. Yes, Karthik, closing statements, please.
Yes, I think it was wonderful. And it's always good to have people like Yogesh and Nikhil who encourage us to do this. Now, I think the key messages are that every gynecologist it's his responsibility to screen for cancer cervix, and everybody should start doing it. I think the first step is to do a per speculum examination, and if we miss it out, we've missed the bus. So pick up a screening method, whichever you like, and probably will evolve a method which is standardized all over. I think it was wonderful to have all 3 stalwarts with us. Thank you so much.
Brilliant. Thank you very much. Thank you so much. Have a great Sunday afternoon lunch. Thank you.